Lepší prostor. Auto. Znáš nejprodávanější značku micelární vod na světě i u nás? Vyzkoušeli micelární vodu pro citlivou vodu od Randíne. Nyní recykované hovano. Micely připádnou nečistoty jako magnet. Odstraní až 100% make-upu. A dokonce i neviditelné nečistoty. Micelární voda pro citlivou vodu doporučována českými ženami.
Alfredo Costavile. Vamos.
Good afternoon, everybody. Professor Armando, nice seeing you. Ramesh, Lucas, Vlad.
Hi, Imad.
Oh, Imad.
I was
Gosh.
Hello, everybody.
I am in Turkey and I thought I would have difficulty to connect, but luckily I am with you.
Great.
Yeah.
Okay,
What is the time for you, Armando, in Buenos Aires?
it's 9 o'clock, 9 o'clock in the morning.
We have, I think, 1 minute, isn't it? And then we
Four.
can, 1 or 2 minutes, I think, is there.
I want to say hello, everybody.
Hi, Francisco.
Hello, Francesco.
Oh,
Morning.
we can wait for a few minutes, no? Because the start is at 2 o'clock.
Yeah, Professor Skanda with us, great. Good to have you with us. You are muted. Hi.
Miguel,
Miguel, unmute yourself. We cannot hear you. Unmute.
Okay, great.
Now we hear you. Great.
Thank you. Thank you. How are you, my friends?
Good
How
to
is
see
life?
you.
You.
Yeah. Good, could be better, but could be worse as well.
Excellent. Excellent. Is our honored guest ready?
Here is winter, and I a little
Yeah.
bit.
Because you have to travel, I know, Armando, he has a flight to catch, and that's why we put him first, and it's our pleasure. I think we will start that session, honoring Professor Armando Passo, a well-known figure in neurosurgery. All these people, they know you by heart. You were a major contribution to the World Federation, honorary president of civil society committees, just name it, and the federation, of course. You have contributed tremendously to the education worldwide. And who else can speak on craniopharyngioma more than Armando Passo, with a vast experience on this subject? We all learn from you. And I think without further ado, Professor Vladimir and myself, we will chair this webinar together. And this session will be chaired with Professor Lucas Rasulik from Belgrade and myself. We'll go ahead, Professor.
Well, first of all, my friends, thank you very much for this. Can you hear me good?
Yes.
Yes.
Very, very well.
Thank you very much for the kind invitations. Really, it's an honor to be with you this morning. And then, more than that, I would like to congratulate you, Vladimir and Imad, for the foundation of this academy, which is very important in this particular moment of the WFNS. So it has been a very, very good idea to create this magnificent group, you know, which in my opinion, group the best neurosurgeons in the world. So thank you for, on the name of the world neurosurgery, your idea is very good. So you asked me to talk on craniopharyngiomas. So can I share with you
Yes.
the what is other participants with? Well, host disabled participant screen sharing. What this?
I think you should be able to do it now.
Okay, good. Can you see this?
Yes.
Okay. I don't know what happened.
We have your.
Okay. Can you see this?
Okay.
Yes.
So let's go to craniopharyngiomas. Craniopharyngiomas, how I do it? You all know very well, it's a rare, benign, not cancer brain tumor that usually forms near the pituitary gland and the hypothalamus. How I do it? So this is the history, transsphenoidal in the prehistoric period, high mortality in the Middle Age period, you know, Renaissance period with large removal. At that time in the 50s and 70s, ventriculography, encephalography, arteriography, hormone. But the best advances was in the time of between the 70s with the microscope, microsurgery that changed the result, of course. And then the present is the most important is preserve the quality of life of our patient and the introduction of endoscopy for the craniopharyngioma surgery. The classification, I remember that when I was in Paris, Jacques Rougerie has because I spent years with Jacques and Professor Guillot, of course, he was the chairman. Well, intracellular, so all those authors has their own classification. I prefer that one of Ghazi because, as usual, was the most simple. And of course, I adopt that. Intracellular, infradiaphragmatic, the diaphragma, intrasupracellular, supradiaphragmatic, etc., etc., etc. That is the classification. But in general, people said prechiasmatic and retrochiasmatic. In reality, all craniopharyngiomas are retrochiasmatic. So the prechiasmatic is just, in general, an extension of a craniopharyngoma, in general, in supracellular position. So that was that. Of the pathological point of view, adamantinomas in pediatric is the most frequent apparition of craniopharyngiomas that sometimes invade out of the capsule, as you can see here. And you can see here an isle of craniopharyngioma cell out of the capsule. In adults, is almost 62%, but the other 40% are papillary, which is the most benign form of craniopharyngiomas in general in adults. The mode of treatment, total resection, in my opinion, is the best, of course. Not always is possible, unfortunately. Subtotal resection plus radiotherapy, in general, is the election that we are obliged when it's not possible the total resection. Radiosurgery, evacuation of the cyst. This is when the craniopharyngiomas had evolution for years, and the cyst produce the augmentation of the problem on the brain. So transnasal aspiration in cases of when we have also a cyst, the most important in adult patients, in all age patients. Cystoventricular connection is the Ostertag technique that sometimes in some cases can solve the symptomatology of the patient when the tumor is still here. Shunting of ventricular system, external irradiation, intracystic chemotherapy, systemic chemotherapy, all the possibilities that we have when it's not possible to perform the total resection, which is, in my opinion, the best. Here, our friend Majid, he said we are not always in agree with him, because Majid, he said, the ongoing discussion regarding infiltration or addition of the tumor to hypothalamus would hinder dissection is no longer justified, because some think that it's possible always the dissection out of the capsule and obtain the total removal of the craniopharyngioma. In my hands, has not been in every case possible. So from the clinical point of view, of course, visual fields is the most frequent symptomatology in patient, neurological sign, neurological dysfunction. This is very important in children. So because we are not pediatric neurosurgeons in our series, the majority of patients belong to this age, young people in between 20 and 30 years old, you know. But in general, we have all type of patients. In our hands, the gross total removal has been possible in almost 70% of the cases, subtotal in the rest. And then let's go to the anatomy and the surgical anatomy now. That means the surgical approach, because craniopharyngioma is in the center of the base, in the basal zone of the brain. It's possible sometimes, dependent on the position of craniopharyngioma, to perform almost every possibilities. But my prefer, what I use in the majority of our cases, is the frontoterional transsylvian approach. Because how I call that transsylvian? Because it's necessary widely open the sylvian tissue. Excuse me, I have a cold that because it's winter in Buenos Aires. So, because the frontoterional transsylvian approach, this is our in transsphenoidal, microscopically talking, even if I personally have a large experience in pituitary, more than 3,000 cases operated, I never liked for craniopharyngiomas. In general, it was in some cases when we believed that it was a kind of, it was a bad diagnosis. Then we went transsphenoidal, microscopically talking. But in general, we go with transsylvian frontoterional craniotomy with the transsylvian approach. In some case, very few cases, we will to orbital zygomatic when the case merit that extension of our approach. The opening of the dura, and when I said the transsylvian approach. The final view is that view that you can approach the craniopharyngioma in the prechiasmatic approach, then going laterally in between the optic nerve and the carotid artery, and external to the carotid artery. In many cases, we are obliged to open the lamina terminalis to preserve and to continue to remove the tumor. That is case of a child, and I don't have time, but I will show you. That means we are going laterally in this case of this child, laterally to the optic nerve. Then we remove the with that approach is necessary to remove the tumor, but be careful to preserve the small vessels, choroidal artery, posterior lateral also. So as you see here in this case, and then of course we clean, we preserve the nerve, we preserve the artery. That's what I mean, the small artery, carotid artery, posterior communicating artery, and then we went to the posterior fossa, as you see here, removing the whole thing. We clean, and we can see here the basilar trunk with the total removal in this case. So you see, excuse me. So the child in the hospital, even in the hospital, with the total removal of that craniopharyngioma. Another case, same thing, same approach. That's why the majority of cases we are doing in that way. Prechiasmatic, lateral optical approach. In this particular case, we opened because it was the suprasellar extension of the tumor was important. The dissection of the so-called capsule of craniopharyngioma. Then the preservation, of course, of the vessels. This is very important. Important if we consider the result, the clinical result of the case. The final view is that view, as you can see here, which is with a total removal also in this case. Another case, in some cases, when the tumor is hard, we use, for instance, the ultrasonic aspirator, as a case in this young person, with the preservation, again, choroidal artery, posterior communicating artery, and all those things. In my opinion, is very important. You see, the sylvian feature is widely open. That give us, a view, a possibility, as you can see here, of all the things. In some special case, when the tumor is intraventricular, we are obliged to go translamina terminalis, as you see here. This is a case with a bifrontal interhemispheric translamina terminalis. You have to be patient trying to present a case like this, trying to preserve and it's interesting to preserve the olfactory nerve. It takes time, as you see here. It takes time, but little by little, we can preserve. Then we go directly to the lamina terminalis, and then the removal of the tumor, preserving the lateral wall, of course, of the third ventricle, and the wall of the hypothalamic. And here, after that removal, we can here the trunk, the pituitary gland, and then at the very end, this is the good result. So the limit of surgical resection in craniopharyngioma, we have to consider the volume, but I put in yellow because the adherence of the tumor to the very important anatomical structures. So that anatomical study, and this is a paper of our dear friend Tetsuo Kano from Nagoya, published in 2007. That means the injury to mammillary body and mammillothalamic tract, that the patient can be awake, but with important disturbance in cognition. That's why we have to try to preserve that those important structures. What do we do in age patient? In age patient, this is a case of a patient of more than 80 years old with that tumor, but the symptomatology has been produced by the cyst. So the only thing that we have doing in those patients is no incise because in all patients just to remove the cyst, and you can see here in this particular case. So the transsphenoidal approach, as I said before, is not my preferable approach. So this is a case because we believe that it was a tumor, a cyst tumor, but finally it was a cryopharyngioma. We removed the cyst and the body of the cryopharyngioma by transsphenoidal approach, but was not, if we have the diagnostic before, our preferable route. But our dear friend Pernesky, in the 80s, he published this supraorbital minimal invasive approach and the removal of many tumors as cryopharyngiomas, and he introduced at that time the endoscopical approach also. I remember I spent some days with him trying with a course, with a very first course organized by Axel. Axel was really a pioneer in all these kind of approaches. So, but now we are very happy because I have one of my pupils, Dr. Abati. He is a full endoscopic endonasal approach. This is 2 cases of cryopharyngiomas, as you can see here. He is working now in my former service of neurosurgery in the university hospital in Buenos Aires. Santiago is he has been working with me many years, so now he is an expert, of course, in endoscopic approach. This is 2 cases. Sorry, this is another case of cryopharyngiomas. Here for teaching purposes, the complete removal of a tumor by complete transnasal endoscopical approach. So we will continue with this. As I said before, total removal was almost in our hands in 70% of the cases, subtotal. So recurrence-free survival total at 10 years, so I cannot see here, 83%. Recurrence-free survival subtotal with radiotherapy and after in only 33% of the cases. So again, radiosurgery. So radiosurgery can be a possibility with gamma knife. My dear friend, Dr. Antico in Buenos Aires, because we have experienced a large experience because the second gamma knife in the world has been installed in Buenos Aires. So Julio Antico, he in some cases when it was impossible surgery, even for cases not my personal cases, he treated those patients with radiosurgery, and he obtained decrease of the size of the tumor in 62% of the cases. This is an example of Julio Antico. He is still working now in cases of cryopharyngioma. In February, in August, in some months, the result was really very, very good in these cryopharyngiomas. This is a combination of radiosurgery with cystoventricular connection, the Ostertag method, with a very good result also. It has been made by Julio Antico also, pre-connection and post-connection. And here you have another case with the symptomatology of the patient was referred to the cyst, to the enormous cyst. So the cystoventricular connection has solved the symptomatology, the important symptomatology that those patients has made. So intracystic therapy has been very, used by many neurosurgeons in the world, even in Buenos Aires, maybe in the group of pediatric, not my group, but in the child hospital in Buenos Aires, which is one of the largest child hospital in the world. They have used Yttrium starting in 82, bleomycin, etc. Well, all those things are not in my hands, as in my group, our preferable treatment for craniophryngiomas. In conclusion, my dear friends, in our hands, transcranial microsurgical approach has demonstrated to be the most effective procedure. The total removal in the first opportunity should be the goal. When this is not possible, subtotal removal should be considered, followed by a complementary treatment, radiotherapy or radiosurgery. All depends the kind of radiotherapy. The radiotherapy, not the traditional, but you know the low intensity or whatever. Or radiosurgery, all depend on the case. And of course, the hormonal replacements, all those things has been in the hands of our very important group that we have in Buenos Aires of neuroendocrinologists. Hormonal replacement depending on the age of the patient or the extension of the surgical procedure and the endocrinological deficit. This is very important in the child population. But of course, once we put the patients in the hands of endocrinologists, we are in very close contact with them during many years. And until now, I have patients that come to my consultation, and we follow those patients over long years. So that's all, my dear friends. Thank you for your attention.
Thank you very much, Armando. Wonderful presentation. Well, over these years,
let me. This is the last slide that belonged to our dear friend Maurice Schooks. That was the Symposium of New York in 1993. At that time, craniophryngiomas was the answer. And then in 2007, the promising answer, okay, was in another symposium in 2007. And in that symposium, always, this is what Maurice is thinking about, that is reasonable surgery. That is reasonable surgery, thinking always in our patient in this particular pathology. This is very, very important. And then you can think in all the other possibility, because the problem is this quality of life of our patients. So we are surgeons. We would like to perform radical, but the radical we have almost recurrences. So when we think it was radical, certainly anatomically was not so radical, but that was our impression. Thank you again.
Thank you, Armando. Well, over the years now, if we observe, we have not gained much ourselves. We have field, we have endoscopy, we have all things, but you showed the important technique in microsurgical technique. The only thing changed, perhaps, the quality of the camera. This is what does advancement in the technology. But the technique, and I like how you peeled the arachnoid from the tumor cyst, that was wonderful to see. And I think all of us, we stress these points, and your words on the endoscopy, you adapted, but not in every case, microsurgery remain the prime management. The other things, endoscopy, you use the cheapest endoscope in your case, which was the mirror at that time, as Julius Hardy said. I saw in one of the cases you put it to see behind the posterior extension. Wonderful. Any comment or question from the podium? Francisco. Unmute yourself, Francisco.
Sorry. I would like to thank Armando, because he told not only us, but told the audience that the primary goal of surgery is total removal. Of course, when you can't remove totally, radically the tumor, you can have subtotal removal plus radiotherapy. But Armando, you know very well that some advocated in the past that the primary option is subtotal removal plus radiotherapy as a planned surgery. So I would like to hear your comment on this strategy, and this strategy which was advocated by some groups in the world.
I agree, dear Francesco, with you. That means total removal, as I said before, maybe is a mistake of we have the impression that we perform the total removal. Everything is clean, etc. And we have then a recurrence some years ago, etc. So in general, maybe it was a subtotal removal. That's what I said. Is our impression that it was a total removal, but when we are confronted with that impossible because the adherence of the craniopharyngioma, that's why maybe I discussed with our dear friend Majid. With Majid, he said, "Well, I remove in every case the whole tumor." Well, maybe Majid is a magician neurosurgeon, so maybe it's possible. But in our hands, not always is possible because the results endocrinological and neurological. What I said, so with the tracts, you can produce a terrible problem on the tracts, on the mammillothalamic tract, and the result, the neurological result of those patients is really a catastrophic result, mainly in children, it's terrible. So I agree with you, Francesco. That means that's why the idea of both treatment, because finally we arrive to both treatment, the radiotherapy or radiosurgery or whatever, the best we can have in our place. I agree with you, Francesco.
Yes.
Any other comment or questions? All right, so you answer all these questions, and whenever you have to leave, Armando, feel free. I know you have another meeting, you have to fly. The next speaker will be myself, and I'm going to talk about central skull base meningioma.
Sorry, I try to invite me again for the next webinars, even if I don't talk. So right. I ran to the airport because I'm sorry to not be with you for the following speaker, because we have to give a conference in the Argentine annual Congress of Neurosurgery, the Argentine Society. So I have to fly to another city in Rosario. Sorry about that. I leave you. Bye-bye.
Okay. Do you see my presentation?
No, not yet.
Any luck?
Yeah, I think it's coming up.
All right. Okay, I'm in full screen now. Do you see it?
Yeah.
Yeah.
All right, so my talk will be on the central skull base meningioma. What means central is an artificial word. I have used it to cover some of the subject around the cella, and I'm talking about meningioma. The evolution in skull base, of course, enlists many people that we all know of them. They have their contribution. And of course, more recently in the endoscopy added Kababenka, Kassam, Bernensky has said, and you. And classification of neurosurgical strategy for these skull-based tumors either can go through authoritative approach that we all learn and adapt it from our mentors, and then we become adaptive to modify a little bit that match our resources and expertise. And if we come with some idea, then we are innovative, which is rarely done. And this gave us a variation of surgical approaches. And we have this, Armando missed that picture. He is in the center of this picture next to his friend Majid Sami. And they were talking about the skull-based approach and the complex one. So 20 years later, we met with the group here, and I can see in the center here, the most important, the tallest is Vladimir with the Arabic gown and dress, and there are Kawazi in front of him. We'll talk about less invasive and move away a little bit from these complex approaches. So there is a trend to revert to the two powerhouses approaches, the terional subfrontal approach and the simple retromastoid. Although quantification of the fronto-orbitozygomatic when we adapted it, it's an amazing, and this was published by Andros, you see, in 1986, almost passing the 30 years, and it gives you, of course, an excellent exposure and multiple avenues. You manage your complication. All these are important, except you added time for this procedure unnecessarily with the new technology, with the technique you are improving, microsurgery, and make use of some of the things I listed here that, as both legend, Professor Yazagil and Sami said, the perfection of microsurgical technique is the sole most important skills for neurosurgery to perform a good surgery. And how you do it with the less invasive, you tailor your approach, you drill as needed, you release CSF cisterna fluid, it gives you space, so less retraction. You don't need always, like the principle, you have to take more bone for the sake more exposure. Taking CSF give you a space. The tumor cavity itself, by a large tumor, it gives you a space. The hybrid use of endoscopy in some cases give you a visual arm extension. And of course, there are other treatment options like the one mentioned earlier, gamma knife and other radiosurgery, and now on the merge gene therapy and other new, there might be for the next generation to stress it and focus on it. So the functional exposure is the most important in these approaches. It has to be safe and short, patient-specific, disease-specific. There is no recipe for all remedies, and you select your approach according to these criteria I'm listing here, with early identification of the vital structure, early basal access, devascularization, they call it the 5D principle. And I still like in the terional approach described by Yazagil, taking the greater wing of the sphenoid is a very important, I think, step, because it gives you really a basal approach to process with the 5D principle to devascularize and then do this some segmental resection, debulking. And the last piece, I will go for the capsule decompression and dissection by maintaining a good arachnoid. So you see any lesion in that area, from the front to the back to the cella, medial sphenoid ring, you can access it with the simple terional or subfrontal approach. This is the position I'd like to use. We make advantage of the gravity. I don't rotate too much the head, because if I need more rotation, I just tilt the table, but you need a good table to tilt sideways. And this is the flap from this dash. I just make this dotted if I need extension, but usually this is the incision I do based on the hairline. And then I leave this piece of island of muscle to be suture. Now you have plating, you don't need this one, but we used to put it to suture the muscle back on it. This is a technique described by Albert Rhoton. And you drill the sphenoid wing, and you drill the medial sphenoid wing as well. And some of the cases, if you need the more bony removal, like in the anterior clinoid or tuberculum celli, you might drill the anterior clinoid from outside inside. The two options are available, but I don't insist on that last piece, because I think releasing the CSF, it will give you these 5 millimeter additional exposure. We have done and published the eyebrow approach by taking the orbital rim, and we published these cases. This is the root of the zygoma, and this is the borehole that is toward the orbit and the cranium. We do a small flap, and this is the exposure you got. This is the function exposure. Whether you expose a whole bone flap or a smaller flap, this is what you are going to use at the end. But here you see little brain, which I don't insist to see most of the brain in that surgery on skull base. So the advantage of opening Sylvian fissure mentioned by Armando is very important. The proximal part I'm talking depends on the size of the tumor. It untethered the frontal lobe from the temporal, so less traction of the olfactory tract, olfactory nerve. Early exposure of the internal carotid, especially in the cases where it's encased the carotid and you don't see the carotid at all, but at least you have the distal part of it to see where you direct you. Release CSF, minimal retraction, injury to the frontal lobe, and early exposure of the tumor. After the devascularization, we'll start the segmental resection from the bottom up and deflect this tumor from the back to the front. So we retract the tumor from the brain, not the brain from the tumor. And Sujita has described the segmental resection. Again, we are not inventing the wheel, but we like to adapt it in our practice. And this is the 5D I have described earlier. One time when we were in Kenya as well, they put the dart and say, throw the dart to the 5D. And important that your dissection respect this arachnoid. This is your naturopathy, as I mentioned. De-roofing of the optic nerve, I found this very helpful in most of central skull base meningioma, because you release the tension of the optic nerve, so you can first identify it if it's not seen very well by the occupying tumor, and it will be untethered, so you can manipulate it without ischemic changes on it. And of course, there is an advantage of the roofing of the optic nerve. So how you prevent vascular injury during the surgery? You review, you in-depth your vascular integrity preoperatively, use Doppler. During the procedure, I frequently use the Doppler to see where the flow is of the carotid or the major vessels. Minimal use of electrocoagulation, a lot of irrigation, minimize traction injuries from the tumor capsule, because these perforators, they go into span, they can lead to a major complication unnoticed. And of course, prepare site for potential vascular graft if you need, although I feel most of these bypass procedures, they have not prevented complication if it occurs. Okay, I will show only 1 or 2 videos. These videos perhaps are, let me see if I show this video here. I'm doing a right subfrontal approach. You see, the approach is very simple. You go down along the frontal lobe, and this is, now we're coming to the area to open the system and put a small patty to elevate the frontal lobe from the skull base without putting a retraction there. So I call it a local soft tissue retraction. And now I am decompressing the tumor. It's not a big tumor, so I decompress it by CUSA, by any tools you have. And now I release it away from the optic nerve on the right side. Put Doppler, because this is where most injuries occur, from the carotid under the contralateral optic nerve. So after I verify where the carotid, I release the skull base attachment, devascularize it. It makes life much easier. And I'll do what I call it trabeculation, take trabecle by trabecle. Once I dissect the arachnoid, I could take this tumor completely out. And this is the carotid on the contralateral side. Looks very good. And a small patty left here. Right, I move to the next. It's another video here. This is the opening we do, release CSF. You see, once you release the CSF is the most important. This is the cheapest tool, is an inverted needle. I open the arachnoid proximally, then use the scissor. and peel the arachnoid away from the tumor. Devascularize the tumor from the skull base. Here I'm drilling and opening the falciform ligament, which is a very important step. I'll do it. Take only a couple of minutes, not a complicated issue. And it relieves the tension of the optic nerve. Now, just devascularize at the skull base. This is the way I do it, tuberculation, and then cut the attachment. Move the arachnoid, and then the tumor can be dissected, maintaining the intact arachnoid to the brain. This is the tumor. Last piece of attachment. And the closure. And this is post-op, looks like untouched brain. This case was interesting. A tumor on the left side, tuberculum celli, but attached to the left. I approach it from the right side. Again, arachnoid opening. Feel the arachnoid, optic nerve is shown. This is the edge of the tumor, so seen at the tuberculum celli area. Same way I'm doing it. Again, taking the attachment step by step. Now I'm drilling the optic nerve canal from the contralateral side. The distance is not far away. So some people say, how do you do it from, it's a very, only 12 millimeter from one side to the other. And you see the hook comes in the canal. And I take it with the Carrison or after I find it, and the falciform ligament and attachment is removed. Devascularize from the base. Doppler is put to identify the carotid. Now peeling the arachnoid. After you devascularize the tumor, it makes things much easier. No blood. And you see arachnoid peeled out. Problem comes when people, they don't dissect the arachnoid properly. This is where you got the breeder and all these things. See, it's a nice. Now, I think we will put the endoscope for the sake of just viewing any residual carotid under the optic nerve on the left side. Third nerve, you see it at the bottom, posterior communicating, posterior clinoid. And on the way I saw this is a small residual here, I will take it out. You see the stalk, pituitary stalk on the corner here. That tumor will be removed on the way out. This is post-op. Very nice without any damage to the frontal lobe or temporal lobe or any structures. This is an interesting case. I think I will show it. I know Dr. Alexander is going to talk on anterior clinoid. Oh, sorry. But I want to show this one because this has some complications. It's an anterior clinoid, a sizable one on the right side. Sorry about this. So again, subfrontal approach with a small piece of growth inside, or this is a plastic. Opening the arachnoid. Feeling the arachnoid. There was one problem, this one, because that tumor encased the carotid artery badly. Feeling more than coagulation. This is the most important. Try to move it forward. We did the devascularization now from the skull base. I'm doing segmental resection helped by the Doppler, because I put the Doppler, I could hear the carotid within this lesion. I split the tumor over lateral to the carotid. You see, the carotid is in the middle between the patents. And I'm trying to dissect this on both sides. First to one side, and then I go to the other side. These are tough cases because you don't use CUSA on these practically, because you might go into the carotid and cause a hole in it, and it could be catastrophic. So I'm taking one segment from one side after I identify the carotid and the A1. And you need to have a good assistant, because you always miss the third hand. If you don't have somebody who can hold things for you and you have your two hands free, it will be very difficult. I'm using my hand to hold at the same time I'm doing dissection. It's not the right things. I should have somebody holding this one properly. And it depends on the trainee level who is with you to do this part. Arachnoid is dissected. Try to move faster. I can see the bottom of the tumor. Arachnoid, move it down. And you see the carotid down. Now you see the carotid and you see the A1, the bifurcation. This is the other side of the tumor that was eventually removed. Well, dissected and taken out. You can see the A1 at the corner and the bifurcation. There is a small atheroma at the bifurcation. Anyhow, you will see the post-surgical. She did very well. But I was not happy with the post-op. We put papaverine to minimize any spasm. You see the optic nerve on the other side, and you see the stroke. A1, and even the hypno vessel, you see the hypno vessel on this. Seeing it is not enough because function might be affected. Good pulsation. This is the post-op. I want to show you, this is not important, this is the approach, but you will see that she got a caudate infarction, but luckily without complication. And when I discussed this one with some experts, they said there's a common thing, caudate infarction might not always give a clinical impact on it. The patient was asymptomatic and left the hospital without problem. So we did several in these techniques. See, these vessels, it just looks like encased, but they are only attached. And this is post-resection. This one, I did not touch the tumor because we see that carotid is in the middle of this conglomerate with the bulk only. And so the outcome influenced by the size, by the invasiveness of the tumor, how aggressive you are, and the surgical experience, age of the patient, and presence of comorbidity. Visual outcome was influenced by the length of and the history of visual loss, preoperatively surgical technique, and we have a referral bias. Thus, we apply Simpson grading on skull-base resection to some extent, but Roberto Hero said, even in grade 1, you have to check always the MIP1 because this is the feature for potential recurrence. So neurosurgical recommendation, well, this is what I mentioned during my presentation. A few words on the endoscopy for meningioma. I don't think this is appropriate to convert a nice clean craniotomy by infected craniotomy in a media where it's full with potential pathogens. You are missing the Simpson grading resection. You leave attachment surrounding that tumor. You are not able to manage your complication properly. There are many of these factors, and the reconstruction is a nightmare with CSF leak. So I still believe meningioma should be done from above, but there are a few cases like this. This case we thought is a chordoma, but we tackle it through transclavial resection, not an extended approach, but except we direct the clivus in the central part. Tends to be a soft tumor, soft meningioma. Basal artery was displaced to the contralateral side as it shows here on this side. So we could remove it as it shows here and see what's happening here to the brainstem by the lesion. It's re-expanded and nicely resected. Actually, Amir and Al-Mufti has described the infradiaphragmatic tumors. These are the cases they might be a consideration for endoscopy. Bifrontal, I gave away bifrontal approach to these cases. You damage two frontal lobe, venous structures, frontal sinus issues, infection. The vascular structure will be seen at the end of the procedure, and it's a long corridor. These are the factors that influence the approach selection. There is an inherent bias by neurosurgical training, surgeon preference, rigidity versus flexibility. This is my way or no way. Cost and logistic, practice trend, people move with the trends. Industrial-driven practice like using the endoscope is much cheaper for them. I thank you very much for your audience. Thank you.
Thank you, Imad, for your excellent presentation. Congratulations for the organization of this outstanding fourth IANA webinar. Somebody would like to comment, to give their some opinion or ask a question.
Just one thing, Imad, you mentioned wabi-sabi concept. I didn't get is that the 5D concept?
No, wabi-sabi is a Japanese lifestyle to accept imperfection and try to improve it. You see, people, they want to be the best, the first, the only. And well, sometimes, as mentioned, craniopharyngioma, you cannot take it completely. Doing a subtotal is not the sin. If you leave something for the sake of having a better patient outcome. So that's what it means. They, in their belief with the wabi-sabi, accept imperfection. And sometimes this is the bottom line. Yeah.
Imad, I like your 5D slide. Decompress, detach, debug. I would add the sixth one, dismiss the patient.
Dismiss him safely. Yeah, well, we'll call it Vladimir 6. Yeah. All right. Now, how I can exit myself from this?
Thank you for the comments. Any other comment, question? If not, once again, Imad, thank you. We move forward. It's my pleasure to invite Professor Alexander Sasha Wozniak to give us his lecture about surgery of clinoid meningiomas. Sasha, glad to see you. I'm glad that you are in a good shape. Please.
Thank you, Imad. So nice.
Floor is yours. Can you hear me, Sasha?
Can you hear me? Can you hear me just now?
If you
I think
can.
the microphone is not working.
The volume is coming, but the volume of the computer should be higher.
Yes.
Better now?
Yes.
No?
A little better, but
A little bit
more. Yeah.
Can you hear me?
Very faint.
Sorry, I'm sorry. So maybe let me move on. I will change my microphone.
I think the microphone you're holding is probably not working. Maybe try without the microphone and connect from the laptop and try.
Maybe we can move forward for the next presentation to switch if Miguel is ready.
Can you hear me now?
Yes.
Okay. I will go on without it, just directly. So thank you very much for invitation. It's a great pleasure and a great honor for me. Okay. Want to remind you, I'm from Ukraine. I'm a chief of neurosurgical department at Hospital Feofania. Today I'd like to discuss, so my lecture is a logical extension of Professor Kanan lecture, but I will focus on the group of clinoid meningioma tumors. We will discuss the definition, anatomy, syncope, surgical approach, the steps of surgery, tips and tricks of the surgery. Sorry. First of all, about definition, I like the definition by Professor Pamir. So he told that the presence of hyperostosis in the middle of the tumor is the main feature of the tumors of the anterior clinoid. Another way to define those tumors is to exclude the planum sphenoidal tumor, the medial ridge tumor, tuberculum sella, cavernous sinus, and everything. The rest will be the clinoidal meningioma tumor. But I want to say that the clinoid in the middle of the tumor is the main characteristic of this tumor. According classification, Professor Cushing separated the group of this tumor at the medial sphenoid wing meningiomas. Another important step in classification of these tumors was the separation of tumors with extradural extension and without extradural extension proposed by Russell and Benjamin. We moved on and separated the second group to the tumors which invade to the anterior process, the clinoidal process, and into the cavernous sinus, so-called group A and group B. We published this in the chapter in this book. Our material was 82 patients operated on during more than 10 years. Recent years, we with a typical clinical presentation, In our practice, we use pterygium and frontolateral craniotomies. Let me focus on some features, characteristics of these tumors, which were most important when we consider the surgical approach, the radicality of the surgery, when we plan everything. First of all, it was the presence of hyperostosis of the clinoid process. The another one was the encasement of major vessels, and first of all, the internal carotids. Cavernous sinus, very important in planning of surgery, in planning of the radical tumor excision. And the last one, which can turn over from top to bottom and vice versa, the presence of brain edema around the tumor. For me, it's very important for planning of the approach. I want to remind you that the clinoidal meningioma are the paramedian tumors. They are not medial, they're paramedian. They shift the optic nerve and the carotids to the midline, so they require the lateral approach. As the clinoid is in the center of the tumor, we must remove this hyperostosis, because first of all, it's a tumor, and another is a feeding point, because the main blood supply comes from clinoid. So that is why the clinoidectomy is the key procedure in this surgery. As a clinoidal meningioma are skull-based tumors, we cannot approach them until we did not relax the brain. The retraction of not relaxed brain is dangerous and harmful. Optic nerve decompression is the main goal of the surgery, and we also always keep the balance between radicalism surgery and functional result and quality, post-operative quality of life of the patient. Now, in our practice, we used two approaches. These are absolutely different approaches. They look similar, but they have absolutely different philosophy, and I will try to explain it, my vision of this. First of all, frontolateral is intradural, pterygium is extradural approach. Clinoidectomy from frontolateral approach, it's very difficult to perform the complete, just usually it's a partial. When you come via pterygium, we can perform the complete clinoidectomy. When we come frontolaterally, we can expose optic nerve and carotids on the final stages of the surgery, after detachment of the tumor, devascularization, and debugging of the tumor. Sometimes it's difficult, as Professor Kanal told, it's even dangerous sometimes for the patient. We must be very, very, very careful. When we come extradural with pterygium, we can visualize the internal carotids, the optic nerve, the superior orbital fissure, and then we will start already devascularized tumor. What I say, because we can devascularize the tumor before tumor removal. Sylvian fissure dissection. It's very good manipulation in cases when there is no brain edema. In case of edematous brain, it's very dangerous, because it's almost impossible to do the good dissection frontal and temporal lobe without traumatization of the brain parenchyma. And finally, the pterygium approach almost doesn't require the brain retraction. So let us go on. Now I present you the step-by-step our surgery. Patient position is a standard. We prefer the big skin flap to obtain the vascularized gallal flap if we need it for plastic. Also quite big a craniotomy. And then we start the extradural stage from drilling of the pterygium. And then, very important, to penetrate the lateral wall of the orbit. This is the first anatomical orientation. When we move along the periorbit, we will reach the base of clinoid. Once we reached it, we separate temporal dura and dura propria, and we have very good anatomical orientation. After that, clinoidectomy, and only after clinoidectomy, we perform the intradural stage. Usually, I try to resect all the invaded tumor as much as it's possible, of course. Then classical meningioma detachment, debugging, and dissection. And wound closure, we usually use the FET for this procedure. In case of frontolateral approach, it's absolutely intradural. It could be performed via eyebrow incision or via the standard hairline, along the hairline incision. I prefer this one because it's better cosmetic result. And after intradural, we start from brain relaxation, from this dissection of sylvian fissure, obtaining and the evacuation of the CSF, brain relaxation, then meningioma devascularization, detachment, debugging, dissection. Optic nerve decompression, clinoidectomy, usually it's a partial clinoidectomy. From this corridor, quite difficult to perform the complete clinoidectomy, and wound closure is usually standard. So let us start from video of terminal approach. We start from the stage of transection of the meningoorbital band and separation of the dura propria and temporal dura. You can see this is the lateral wall of the cavernous sinus. I accomplished the clinoidectomy. In this case, it was much easier to use the Carison than drill. It was inconvenient. Then I resect the invaded dura along the border of tumor fixation. This is the optic canal. I move along the optic nerve to reach all the tumor in the canal and decompress the optic nerve and remove the tumor. Then I go back along the optic nerve. Here are some adhesions. Debug the tumor, which is important to obtain the additional space, to obtain the CSF to relax the brain. Then I go to the carotis. Here I can use accuser because I see all the important anatomical structures. This is a internal carotis. Now the tumor is completely dissected, the third nerve, dissected from the origin point. Some adhesions with the carotis. At the stage of dissection, I prefer the sharp dissection. It's less dangerous, especially in terms of sacrificing the small vessels. This is the final view. Frontolateral approach. After CSF evacuation, I debug the tumor, devascularize it, and move on to the optic nerve. It's very important to visualize the optic nerve first. You can see the optic nerve, ipsilateral, compressed and shifted. Go on. Now the tumor is devascularized. It's quite easy to remove it after this. Then you can see in the internal carotis next to the optic nerve. Again, debugging. In this case, the carotis was engulfed by the tumor, not without severe adhesion. It was quite easy to just pull it from the suprasellar region and dissect from the posterior communicating artery. Then we visualize the third nerve and remove the tumor completely. This is, we accomplish the tumor removal. So the tumor been removed completely. Next step, I remove the invaded dura. it's important to prevent the recurrence of the tumor. Then partial clinoidectomy. In this case, there was no hyperostotic clinoid. That is why we used frontolateral, and we performed only partial clinoidectomy. We accomplished the tumor removal from the lateral wall of the cavernous sinus. So now the removal, this is a final view. Here I presented you the final view after pteronal approach, internal carotis, optic nerve, lateral wall of the cavernous sinus, third nerve next to the internal carotis. From this point of view, we can very well control the lateral wall of the cavernous sinus. From the frontolateral approach, we can control better the optic nerve decompressed in optic canal, internal carotis, and the suprasellar region. Some tricks and some important points of this surgery, and I think the separation of dura propria and temporal dura is crucial for surgery of clinoidal meningioma. Once we dissect it, I want to say that even in cases when meningioma invade into the cavernous sinus, we can separate dura propria and temporal dura. As we have the lateral aspect of the cavernous sinus, we'll never sacrifice the structures inside the tumor. This is the body. If we will stay on this body, we will never sacrifice the third nerve, the internal carotis, and so on, so on. The next clinoidectomy. Once more, clinoids. It's such a key point for all this surgery. Once we remove it, we can access the superior orbital fissure and all the anatomical structures inside, optic canal to decompress, and canal of internal carotis artery from the internal fibrous ring to external fibrous ring. Only after this we can go more intradurally and work with the tumor. Next, and another important point: the dura incision at the pteronal approach. We do not cut dura along the sylvian fissure, and this dura let us to protect the brain from additional retraction, additional traumatization. Resection of the dura, of the invaded dura. Usually, I try to resect it, but here we must be very, very careful, especially from one side, it's a border of the cavernous sinus and internal carotis at this point. And here, and also here could be a big draining vein from the medial temporal vein. So this also will be the border of our resection when we remove the invaded dura. Dissection. I told you that I prefer the sharp dissection. Here, the internal carotis, this is middle cerebral artery and small branches. At the stage of dissection of small vessels, of penetrators, I'm not aggressive, and sometimes I remove a piece of tumor to preserve the small cyst. A few words about brain relaxation. It's very important in patients, for patients with any skull-based tumors. Pre-op therapy can provide us some decrease of brain edema, to release, but patient position also will help us to get additional relaxation, additional venous blood outflow. But the main procedure for CSF DREAM is a cistern opening and evacuation of CSF from cisterns and sometimes from ventricles from cysts. We do not use a lumbar CSF drain for many years already, but sometimes it could be wise to use it. Intraoperative medication can help only for a short period of time, just to provide you the real surgical decompression. Tumor resection and decrease of tumor volume, and also tumor devascularization also can help you to relax the brain. Very rare, sometimes. It's possible to perform the brain resection. This is the illustrated case operated on by the pteronal approach. Clinoid resected, MRI in 3 months after surgery with a good functional result. This is our result. We were not so much radical, less than half tumors were removed completely. Majority of the tumors were removed subtotally. In cases of tumor regrowth and in cases of atypical meningioma, we recommended the radiosurgery for the patient. So to summarize everything I presented you, so I want to say that clinoidal meningioma extension to cavernous sinus, bone invasion, and peritumoral edema were the key indicators for the surgical approach choice. Frontolateral supraorbital craniotomy considered patient with the without anterior clinoid hyperestosis. Hyperestosis of anterior clinoid, extension to the cavernous sinus, peritumoral brain edema, urged us to use the pteronal craniotomy. Pteronal approach provided early extradural access to the optic nerve, internal carotids, lateral walls of the cavernous sinus, brain relaxation, and did not require severe brain retraction. In conclusion, step-by-step surgery with identification of critical anatomical structure was the key for safe and radical excision of clinoidal meningioma. Brain relaxation, minimal brain retraction, complete optic nerve decompression, sharp dissection of anatomical structure, preservation of veins, removal of invaded dura and ball, no attempts to remove the tumor from the cavernous sinus were mandatory. And patients' post-operative quality of life was the main goal of clinoidal meningioma management. Thank you for your attention. Tomorrow is our Independence Day, so I congratulate you and my country. Thank you very much.
Thank you, Sasha, for this excellent presentation. Congratulations on your Independence Day. I'm very glad that you are in a good shape. I am looking forward to seeing you in Belgrade and of course, and beyond. Before I give sharing to the email for the next, I have to ask all presenters, because I believe that this question, so which are in a Q&A box, are can be related to the whole presentation. So if you, Sasha, you are like to answer, or anybody else, we have a question for Tarik Einbrook. Some case presented with hydrocephalus with CSF diversion. Should we did VIP shunt insertion before surgery? And regarding visual impairment, how percentage surgery will improve visual impairment? So these are the questions in the Q&A box.
So is this the question for me?
First question is about the presented hydrocephalus, which needs CSF diversion. Should we do shunting insertion before surgery?
I think that in cases of clinoidal meningioma, there is no sense in shunting procedures at all. In some cases, we can perform the drain of the ventricle before procedure. In cases of posterior fossa tumor, sometimes we recommend but for anterior and middle fossa, I think there is no sense.
In my practice, I never have a major hydrocephalus from a central skull base meningioma or anterior clinoid meningioma. But in a situation, you don't commit a patient for a permanent shunting because it might be trivial. So if at all you need it, you do an EVD. But
I think that these questions were for the craniopharyngioma talk, I think.
Right. This was the question for Armando.
Armando,
Yeah.
so I think we'll have Armando to answer this one.
Yeah.
Okay, let's
Can
move.
I ask one question, Imad?
Go ahead, yeah.
I want to know from the speakers,
Well with us, yeah. Hey.
I want to know the status of orbitozygomatic osteotomy. You see, about 20 years ago, I used to do orbitozygomatic osteotomy, removal of lateral wall of orbit, going basal, and all those things I used to do on a very regular basis earlier. I want to know from the panelists, what is your current status of orbitozygomatic operation and whether you do it and whether you recommend it. As far as I am concerned, I have completely abandoned it. For last several years, I have not used it. So I want to know what is your situation at this point of time.
I think I mentioned my situation. The only option for this, people going for a cavernous sinus surgery. This is where you need the orbital rim to be taken to give you more basal access. But in my practice, I abandon this in general. I am not rigid, you see. If I need it, I'll do it, but not the full loaded fronto-orbitozygomatic. I might drill more the orbital rim from inside, but in the practice, if you are asking what is the trend, I gave up this practice in general. But,
Exactly the same. I never use it anymore. It's too much.
I used it in the past, but only for so-called spheno-cavernous meningiomas, but very few cases. Really, I abandoned this approach.
I believe this is exactly what Alexander has said, that he never enters the cavernous sinus, nor do I. I believe that since we have the radiosurgery, we shouldn't be entering cavernous sinus because of the carotid artery, all the nerves there. It's I don't see a point chasing meningioma into the cavernous sinus.
Atul, I mentioned why the reason we moved away. Because we have the option to release CSF, to resect tumor, use the cavity of a tumor. You have endoscope to give you a visual arm to see beyond your resection area. So all these together compensate. The problem, nobody has done a functional anatomical evaluation of the exposure you have. They do it all on cadaver by injecting silicone. And they say this is the space you get when you take the orbitozygomatic with it. So the space, of course, as a space is bigger, but nobody is doing a functional evaluation on an active case where you release CSF, you take a tumor, you give mannitol, you use an endoscope. These studies does not exist, and that's why the people become rigid that fronto-orbitozygomatic is a better exposure based on these studies, which is cadaveric study.
Miguel, you would like to ask something?
Well, thank you very much. Just answering my good friend Atul Goel, I'm thinking I'm doing it in the same way. I think we have abandoned this concept. We only do limited zygomatic osteotomy in cases you need to elevate the temporal lobe region and you want to, let's say, diminish the bulking of the temporal muscle. This is the only usefulness, to my mind, of the zygomatic osteotomy. That can be a very limited zygomatic osteotomy reflecting downward temporal muscle. But the conceptual COC craniotomy as device 20-25 years ago, we have abandoned that for meningioma surgery.
Yeah. Can I add something to that? The indication for OZE is when you need to go higher up above the posterior clinoid. And those are the craniopharyngiomas and high positioned basilar bifurcation aneurysms. These two indications, when they were reaching very high above the posterior clinoid processes, was real good. But now the aneurysms of this type are treated endovascularly and craniopharyngiomas mostly endoscopically. So I don't really see any indication for this approach anymore.
Yeah.
So we abandoned. We do not use this approach. I prefer to use different trajectories to approach the tumor, 2 or 3 different trajectories, but not perform the big, this traumatic craniotomy.
Okay, shall we move forward? Imad, you would like to announce next
Yeah,
speaker?
give the next one and then we can release you. You have something to do. I think you have another meeting. You are in.
No, it's okay. I'm fine. So far, I'm good. So we can continue until the end of the session. Yeah.
You go next yourself.
Okay, so it's my great pleasure to announce our next speaker. This is Professor Miguel Arez, and he will speak us about challenges of the surgical removal of brainstem tumors.
Okay.
Miguel, floor is yours.
Thank you very much, my friends. First of all, I'd like to congratulate. I think this is, to me, the first opportunity to congratulate my very good friend Imad Kanan and Vladimir Benes for the wonderful initiative in regard to the International Academy of Neurosurgical Anatomy. And also, I think this is a great initiative just to honor Dr. Basso. Dr. Basso, I do love him, and I will mention something about his, let's say, neurosurgical figure with your permission at the end of my presentation. Brainstem tumors is a very large topic, and we just decided to focus on mesencephalic brainstem tumor, something like 360-degree approaches to the mesencephalic brainstem tumor. I think that there are several key issues regarding brainstem tumor. My presentation will focus on adult brainstem tumor that is almost synonymous of cavernoma, surgical indication, timing, safe removal that is related to the safe entry zone and the dissection playing around the tumor. And talking about the entry, we have the more and more popular concept of safe entry zone, and also some other tricks like the rule of the 2 points, just pointing out the center of the lesion, and another point, the second one is placed in the closer vicinity of the surface of the brainstem, so you can figure out the way of your approach. I think that basically what we have to do is just counterbalance the natural history of the lesion and the advantages and disadvantages of surgery. And I think that this is something important, this slide, the indication for, the good indication for surgery, I think very well known by everybody. First, second, symptomatic hemorrhage, recurrent hemorrhages, lesions at the medullary area that are very, let's say, harmful for the patient. Exophytic lesion, apparently easier to be removed, mass effect, and altered consciousness that is almost synonymous of lesion, big lesion, and last indication for surgery could be severe and progressive neurological dysfunction. But even more important, that good indication for surgery is just taking into account bad indication for surgery. Patient with few or no symptoms, small and or difficult to be accessed, lesion, deep lesions, minor hemorrhages with rapid improvement, asymptomatic lesion, and those located in the area below the foreventricle, because they are very, very risky for the life of the patient. So just trying to follow one of the mainstay of this international academy that is trying to combine the value of neuroanatomy with the neurosurgical approaches, this presentation will be almost divided into two parts. One of them very important regarding the midbrain anatomy, just the way to understand how can we access this critical area of the anatomy. And it is my pleasure just to mention Dr. Pablo González, because we will use his anatomical preparation. You will be how superb they are. Of course, you all know Pablo González because he's one of the outstanding member of the International Academy of Anatomy. And this is a beautiful set of slides. Mesencephalon, midbrain connect the metencephalon with the diencephalon and upper telencephalon through the cerebral peduncle. We can see just top left this ventral view. We have the cerebral peduncles in intercrural fissure, the exit of the third nerve, the pontomesencephalic sulcus, and nearby you can see in this lateral aspect the exit of the fourth nerve. This is a posterior view with the neurovascular structure. This is a pure posterior view of the pineal region with the superior and inferior colliculi. If we go here, we can see the relationship between mesencephalon and the upper part, that is diencephalon and telencephalon, and also the relationship with the rhombencephalic structures that are represented by the metencephalon and myelencephalon. Important to mention the relationship between tentorium and lateral aspect of the mesencephalon, very useful for certain approaches. And finally, another important classification, anterolateral aspect, is related to the cerebral peduncle. We can see here the representation of the posterior mesencephalon with the colliculi. This is the collicular area. And in between, we have a very sensitive and very difficult region to be managed, that is the tegmental area. Of course, this is aqueduct of Sylvius. And if we want to get inside mesencephalon, we have to go through the water, because the mesencephalon is surrounded by CSF, anteriorly represented by the interpeduncular cistern. Lateral, that is the parapeduncular cistern, is composed by the ambient and crural cistern. A lateral aspect is represented by the quadrigeminal cistern, whose upper and posterior extension is related to the velum interpositum. And this is the way we have to consider the mesencephalon. And we have some views. This is a pure anterior view. This is basilar artery and perforator. So to my mind, there are several descriptions about approaches through this way, but I see a lot of inconvenience. First of all, because sometimes you have to directly deal with the third nerve, and of course you have basilar artery and all the perforator in between your way. This is an anterolateral aspect of the mesencephalon. You can see the lateral mesencephalic sulcus to get orientated, and this is the uncal region of the temporal lobe. This is a posterolateral view. This is the fourth nerve. This is tegmentum, lateral mesencephalic sulcus, and just bottom right, you can see the collicular, the superior and inferior collicular tubercle. And this is something just trying to summarize some of the safe entry zone. This is the entry zone medial to the exit of the third nerve. I have never used that, to be honest. This is the supracollicular area. You can see here medial and lateral lemniscus, and this is the frontopontine fibers. And here, exactly, you have the lateral mesencephalic sulcus. That is a very well-known landmark to get inside the tegmental mesencephalon. If we go to the first example, ventrolateral lesion that is synonymous of cerebral peduncles has been described the COC approach. Also, you can do, according to the extension of the lesion, the subtemporal approach. Actually, the only real safe entry zone is the lateral mesencephalic sulcus that is rather posterior and cannot be accessed through this anterolateral aspect. And as I mentioned before, this is one of the pictures taken for the medical literature, just showing the COOC approach that is time-consuming, provoking potential morbidity, and so. And just in certain cases, what you like to do is a very limited zygomatic osteotomy, as you can see here, and the fixation with mini plates is very easy done and easily done. And as I mentioned before during the discussion, by the way, of the wonderful presentation of my friend Oleksandr Voixnev, we only use this limited zygomatic osteotomy when we want to have the temporal muscle displaced downward, so you can elevate the anterotemporal region of the temporal lobe just to access tentorial incisura. And there are several examples. We have done that in certain cases of high basilar tip aneurysm, and we have used that in many cases of middle fossa approach for Petrus apex in broad sense lesion. These are our indication for this limited zygomatic osteotomy. This is a young patient, pseudocystic lesion, contralateral left side progressive hemiparesis, and you can see here the way we have elevated the temporal lobe. The more temporal muscle you have, the more you have to retract temporal lobe. So this strategy of the zygomatic osteotomy is useful, trying to diminish retraction. And this is temporal incisura, the lesion at the right side, and of course this is third nerve, posterior cerebral artery, by definition superior cerebral artery. This is posterior communicating artery, and this is the lesion that has been very easily removed with a very nice postoperative MRI, but the patient after the operation became completely hemiplegic. You can see the patient 4 months after the operation, and this is the patient, 16 years old patient, piano player. This is 9-10 months with, thanks God, full recovery of the function and playing piano. And this is the anatomical explanation, again from 3D anatomy group, Pablo Gonzalez and his group. And we can see the explanation. This is the corticospinal tract at the pontine region with some loosened distribution, but at the crural lateral aspect of the mesencephalon, all these fibers are very compact, and any movement over here will provoke hemiplegia. Another lesion at the mesencephalon. This is a very lateral lesion, and if we take into account anatomy, we can see how easily the simple subtemporal approach is able to manage and remove this lesion. We are at the right side. We can see there some venous anomaly. This is the fourth nerve. Something over there pointing out toward the lesion. Cavernoma being removed. This is the cavity after preservation of the fourth nerve and the cavity after removal. This is MRI, and this is the patient. During admittance, the patient had at the first episode complete left side dysesthesia that went back and recovered, and after the operation, a slight diminish of the sensation that went back to normality with this very nice case. This is another mesencephalic lesion. You can see this lesion in the center. You can think about going through the intercrural cister. As I mentioned before, we have never done that. We don't like that with the basilar artery of the perforator, and see the distortion of the mesencephalon We treat the patient conservatively, but the patient came back after impairment and we have to do something. It was a 21 years old patient. So we decided to go through the infracollicular region, see the collicular region and see the displacement of the tumor. So it seemed to our mind the way of trying to approach the lesion. By the way, by means of a suboccipital transtentorial infracollicular approach, we can see here the exit of the fourth nerve, very seldom seen in our classical neurosurgical approaches. Some staining over there. We did some small opening, and the way of entering brainstem, if you are not dealing with a safe entry zone, is just making some small puncture and elongating and opening little by little. Bottom left, you can see, sorry. Bottom left, you can see after removal of the tumor, the basilar bifurcation. So we have the tumor and we had completely transected the mesencephalon, and bottom right, you can see the inferior colliculi, and this is the view of the surgical field. And well, this is the postoperative MRI. The patient had a hemorrhage at 6 hours after the operation. We removed the clot, and this is the postoperative MRI. Histology, melanocytic tumor. We are always thinking that everything inside brainstem is either glioma or cavernoma. At least 10% of the lesion are not even a neoplastic lesion, and among the tumor, there is a huge variety, including this possibility, a complete benign tumor, the melanocytic tumor. So mesencephalon tectal region is very straightforward approach by means of suboccipital transtentorial approach, cerebellomesencephalic sulcus. Sorry, you can see here this huge artery, just giving the explanation why sometimes cavernoma is bleeding so much. And just at the bottom of your screen, you have seen the in toto removal in a very easily approach. This is the patient during admittance, some limitation of the upward gaze that the patient had before the operation. This is a very rewarding operation. And last example of the mesencephalon is not the crural region, the peduncles, is not the collicular area, it's tegmental area, as you can see here. This is a young patient with suspicion of glioma and spectroscopy pointing out high-grade glioma. Just the way of removing that, there are many publications. This is one of the group of Professor Spessler, even exposing sagittal sinus. What you have to do is suboccipital craniotomy, exposing transverse sinus, doing some limited osteotomy, allowing you to reflect upward the tentorium. And this is our case. We are at the right side, Vermian region, mesencephalic vein that is pointing out the lateral mesencephalic sulcus. This is the superior cerebellar artery that is abandoned the mesencephalic segment at this ambient cistern. The lesion almost self-exposed, occipital lobe, a very important surgical tip. You have to open and cut tentorium from below, and that way you can reflect, in this case, to the right side, the occipital lobe, in order to get enough angle to get laterally the mesencephalic region. This is some video. This is the lesion, almost self-exposed, right side, and just underneath, after removal of the lesion. Histology, pilocytic astrocytoma. This is another lesion, almost the same lesion. Spectroscopy, malignant glioma. It was a young patient, 40-something, see this funny vessel. We thought that at least we should try to get a biopsy and try to do our best. We just get through the same approach. The patient was bleeding like a real AVM. It was a complete nightmare, the operation, because of the sensitivity of the mesencephalon and the risk of postoperative morbidity. And this is the patient MRI after the operation, histology, vascular malformation, no tumor. And this is one of the MRI during the follow-up. And this is the patient. The patient had some left side hemiparesis that little by little improved. This is few months after the operation. And gaze very well preserved with the aid of some small ophthalmological procedure. Pretty satisfactory result. So this is the summary of the 360-degree approaches to mesencephalic brainstem tumor. Of course, this is a complex anatomy. We need the anatomical definition of the lesion, the concept of the safe entry zone, but what is, of course, microsurgical technique, but this, what is underlying all this presentation is the full sense of the focus of the International Neuroanatomy Academy, trying to get together the anatomical neuroanatomy and the neurosurgical approaches. And I think brainstem is a good example for that. And I had prepared some few slides talking Professor Armando Basso, leader in neurosurgery, master of masters, fruitful international career. You know all that he became more than 20 years ago president of WFNS. He has received many honors and recognition. This is in Malaga, receiving the highest recognition of the Royal Academy of Medicine and Surgery in Andalusia. This is somewhere else, receiving another medal. We were joking, and I was just trying to check the quality of the gold of the medal. Wherever Professor Basso is, many people around him, he is not only a bright and visionary neurosurgeon, he is also a wonderful person and a very funny person, reason why he always have a lot of people. But needless to mention, his abilities and, you know, so many activities in the international political neurosurgical arena. And if you look at this site, you can imagine how difficult enemy he could be if you want to fight Professor Armando Basso. So take care if so. This is in Malaga in another meeting of the AC WFNS AC with many friends. We have met, fortunately, we have met in many places. I'm truly honored, consider myself a friend of Professor Basso. He taught me a lot of things, and for me it's amazing having met him. This is a very important picture because Professor Basso, one of his greatest accomplishments was his management and the boost to the WFNS Foundation. I don't want to speak about WFNS, but let's say that WFNS Foundation is the nicest face, and to my mind, what is really giving sense to the whole organization. And this is one day, more than 20 years ago, in which fortunately Professor Basso was signing some agreement with the leadership of B. Brown Esculap in order to provide neurosurgical equipment for developing countries at a very, very, very cheap price. And you can see here Professor Basso in one of the meetings. He is always pointing out the key issue wherever and whatever the issue is. Could be a neurosurgical issue, could be a political international issue. He is always pointing out the key point with some wise and experienced way of doing things. Always or almost always with his lovely wife Milva. I wanted to make this small tour just to, on my humble side, honor Professor Basso and contribute to this wonderful webinar. Thank you very much, my dear friends.
Imad, would you like to continue?
Yes, let's have some comment or question for Miguel. And
I would have two short questions for Miguel. Miguel, how frequently do you check up on patients whom do you not operate with cavernomas? What is the frequency of?
Well, we follow them, and those who has not been operated very frequently are either old patient or with discovery of some minor hemorrhage when the patient is let's say old, or young patient with asymptomatic lesion or lesion that have some small bleeding with full recovery. If the patient,
what is the frequency of MRs in your hand?
In the patient that already bled around every 6 months at the beginning.
Okay, and the next short question, did you see the brainstem cavernoma without venous anomaly?
Oh, yes. Sometimes you see venous anomaly, very prominent venous anomaly, sometimes not. Of course, yes. Thank you.
Thank you.
Imad?
we did not have there was a question from Vladimir. Was it here and answered?
Miguel has answered.
Okay. All right. Any other questions? If not, we move to our caro amigo, Professor Francisco Tomasello. He is known to all of you. He is the professor of neurosurgery, a major contributor in the World Federation, chair of different committees, president of different societies. And I think you don't need introduction because your expertise in the different field, but this is an add-on talking about intradural spinal tumor. I would like to hear these topics from you, Francisco.
Thank you so much. I would like to tell you and Vladimir that I am very delighted to see in this occasion several friends. Unfortunately, we don't meet in person, but I hope that will happen very, very soon. And I think that I am really consider a great pleasure and privilege to participate in this webinar because, excuse me, because, okay, you see my screen?
Yes.
Yes.
I am very happy to participate because this webinar, as usual, under the excellent organization of Imad Kanan and Vladimir Benes, is honoring Professor Armando Basso. Miguel already made a really very interesting overview of meetings and occasions, but I know our Professor Armando Basso since several years. This is a picture including Miguel Arraez and Yoko Kato and it's a very good memory. You agree, Miguel? It's a good memory.
Absolutely, my friend. Absolutely.
Okay. As you said, my presentation is dealing with the surgical treatment of intradural spinal tumors, and from the epidemiological point of view, we know that these are relatively rare tumors. Extramedullary, the more frequent histotypes are schwannomas and meningiomas, and intramedullary ependymomas, mostly ependymomas, and more rare astrocytomas. I would like to mention a very important literature review of astrocytomas and prognostic factors in a paper of the group of Vladimir Benish, and I think that this is very important. The only failure that with astrocytomas, which we know are the most challenging tumors, we have almost only retrospective studies. Key points of these tumors: 5 to 15% of primary CNS tumors are spinal. Most primary spinal tumors are benign. Clinical presentation mostly due to compression rather than to invasion infiltration. But surgery for anaplastic ependymomas and high-grade astrocytomas remains a really very difficult task. Microneurosurgery, advanced imaging, and intraoperative neurophysiological monitoring have improved the neurological outcome and sometimes or often also cure of patients. The approach to intramedullary tumors, as we know, is the posterior midline myelotomy with retraction of myelotomic borders by means of pierced stitches. But the most important thing is to identify the plane between tumor and spinal cord. This is absolutely crucial. And gross total resection is really mandatory, but taking into account the functional preservation of the, as you see, the sulcus between posterior columns is the right way to access the intramedullary tumors. Sometimes, as was advocated also by a great friend of mine, Gianpaolo Cantore, at the beginning of this century, sometimes a discontinuous myelotomy may be helpful. And also in my personal experience, I had some cases in which I used the discontinuous just to have an approach to the tumor from both sides, and this may facilitate the removal of the tumors. For tumors laterally located, the approach, the best approach is through the sulcus between the dorsal column and the lateral column, just close to the root entry zone. This is a very small groove, and myelotomy can be performed in this area for laterally located tumors. This is, in my opinion, an important paper because it establishes that the tumor histology has a great impact on resectability and the neurological outcome in the primary intramedullary tumors. And as you see, if we look at the gross total removal, the best chances are for ependymomas. And far less for astrocytomas and other types of tumor. And the same, the neurological outcome is better with ependymomas. Sometimes they remain stable, but as you see, other tumors, especially astrocytomas, have worse prognosis and results. There is a paper emphasizing the current evidence-based recommendation for the treatment of intramedullary tumors. Surgical resection is the best treatment option for all intramedullary tumors, probably except for astrocytomas. The removal of these intramedullary tumors may have in the neurophysiological monitoring an important aid, and probably more than motor evoked potentials is important. This is an Italian contribution, the D-wave. The contribution is in 2007. If we have a decrease more than 50% of the D-wave lost bilaterally, we can predict a permanent motor deficit. In these cases, we have to stop surgery immediately. If a D-wave does not recover, probably it's better to abandon surgery. This is the most important guide for our behavior during the surgical procedure. This is the protocol I used: free running EMG, SEPs, MAPs, but especially D-wave, with in some cases direct nerve stimulation as our most important tool in the operating room. I would like to illustrate very few cases. This is a female 17 years old who came with severe tetraparesis, and this was an ependymoma from C3 to T4. We used, of course, the D-wave recording in this case, and the midline myelotomy, always with the assistance of the neurophysiological monitoring. And you see here that we've tried to find the plane between the tumor and the spinal cord. As you see here, this is the anterior portion of spinal cord. The tumor was very extensive, of course, and step by step, utilizing the intraoperative monitoring. The tumor was more than 11 centimeters, and at the end of the procedure, you can see that there is a D-wave well represented, so as well represented as it was before. The PL suture of the closure of the myelotomy, and the postoperative MR, as you see here. And this case, of course, was underwent a stabilization with the screws, and just to avoid any problem, because the tumor was really very extensive. And also in low-grade astrocytoma, is in this case upper cervical spinal cord, not always we are able to perform a very complete resection. It depends on the neurophysiological monitoring, and in this case, a small remnant in this intramedullary tumor. Sometimes this is a bulbomedullary cavernoma, and sometimes is useful to have a DTI, a tractography of the cortical spinal tract in relation with the tumor, just to have an idea of the relationships between these structures. But always, also in this case, with the neuromonitoring, and this is the patient after the operation. the majority of ependymomas are mixopapillary ependymomas. They are about 50% of all ependymomas in the spinal cord. And you see this case, which is T12L1. And there's, of course, a problem to dissect the tumor from the roots, also with the use of ultrasonic aspirator. And the dissection, you have a great friend, which is the arachnoidal plane, just to avoid to injury the roots and the medullary conus. I go fast because, of course, at the end we have an electrostimulation and the recording of the roots, and this is the post-operative control in this case, and also with T2 imaging. As you see, the tumor was at the distal portion of the spinal cord. Another frequent location is the filum terminale of mixopapillary ependymomas, is the filum terminale and the cauda equina. This was a young boy. You see always the arachnoidal plane. And the protection of roots. And at the end, removing the tumor. We see that there is a portion inside the filum terminale, as you see here. And I needed to remove also this, resecting the filum terminalis. The extramedullary, as we know, are meningiomas and schwannomas, mostly found in extramedullary space. And also in these cases, the role of neuromonitoring is absolutely mandatory to use neuromonitoring also for this case. This is a relatively young male, 31 years old, with the meningioma T5, T6, very large, as you see in the axial scan. And during this operation, maps were lost during surgery. But for us, it was important that there was a well-registered wave. And I would like to mention a sentence of Francesco Sala, very recently published on neurosurgery. No patient should be deprived of intraoperative neuromonitoring. Why this sentence? Because there was a debate also in the same journal that probably was not completely in favor of neuromonitoring. This is, I think, is absolutely wrong. Neuromonitoring probably will assist us for several years in this surgery. And this is the case of meningioma after operation and the control, post-operative control. Another case of meningioma, always grade 1, extramedullary, in the upper cervical spinal cord and the postoperative control. And another important histotype are schwannomas of the spinal cord. In this case, I used, as was suggested by a great friend of us, Keiki Turelle, in this paper, the hemilaminectomy approach, not a complete laminectomy. So as you see here in the post-op control, the access was through an hemilaminectomy. Absolutely, I agree with Keiki Turelle and other colleagues advocating the hemilaminectomy as approach to this tumor. And you see here that the tumor was, of course, laterally, and you see, of course, with the use of ultrasonic aspirator, the removal of tumor, also in the foraminal portion, and also in the extraforaminal portion. At the end, we can see that there was, you see the opening of the dura, which was lateral, of course, the lateral portion of the spinal cord and the root. And you see also that the dura protected the spinal cord during the tumor resection. You see here. And this is the case 30 days after operation with a small injury of the spinal cord, but it was preoperatively shown. And the problem of the results of these tumors. Ependymomas we can remove in most cases, we can achieve a gross total removal. The neurological deterioration, it depends on the preoperative McCulloch score greater than 2, and of course subtotal removal are negative predictors. For astrocytomas, we can have some successful removal with grade 1, but in high grade, depending on infiltration invasiveness, we saw that there was no influence of extent of removal on the neurological deterioration. Probably, and also in recurrence. For meningiomas, of course, we can remove largely these tumors, and schwannomas, and the most frequent complication is a CSF leak. But this can be solved very easily with some of course, some measures. Myxopapillary ependymomas, filum terminale and cauda equina, the result may depend on risk of injuring nerve roots, as we saw. And the bowel and bladder incontinence are the most important neurological problems after operation. Recurrence rate, also in gross total removal of this tumor, is about 15%. In conclusion, when we look at the future, what we can say about intradural spinal tumor? Gross total removal is feasible in most intradural spinal tumors. Intramedullary tumors are the most challenging spinal lesion. Neurological outcome depends on pre-op McCormick score, tumor infiltration invasivity, and extent of resection. And in astrocytomas, we have two different attitudes. For low-grade astrocytomas, some authors advocated aggressive surgery, and probably I agree with this strategy. For high-grade astrocytomas, I would like to mention a very recent paper published on Journal Neuro-Oncology of a multi-center, always retrospective, as I said before, study, but the recommendation at the end was biopsy or as possible tumor debulking. This is the situation for high-grade astrocytomas. Investigations on intraoperative image-guided resection are ongoing, and we hope to have more information from imaging. And neuromonitoring can guide the surgical strategy and predict the neurological outcome, as we saw before. Further advances are, of course, expected from molecular investigations and possible nanomedicine or target therapy, that all these measures are under evaluation, and we hope that they can be successful, especially for high-grade tumors. I thank you so much for your attention, and
thank you, Francisco, for this wonderful presentation. Well covered both intra and extramedullary tumors. I might start with one comment that you mentioned about the hemilaminectomy for one of the cases, like a Kiki, and we all like this approach. But about laminoplasty for this extensive cervical cases. You have a case that has gone over multiple levels. Do you recommend it? Time consuming? What is your take on this one?
You are right. Probably in the first case I showed you, probably I have no great experience on very extensive laminectomy, just to have a laminoplasty. So I was afraid that this was not so important for the stability of this segment of because it's a cervical and upper thoracic segment. So I decided at the end that it was better. But in this case, for less extensive tumors, laminoplasty may be a very important approach. I did not mention Yazri because the first time I learned about hemilaminectomy, but from Ghazi Yazri. Ghazi Yazri was advocating in many cases hemilaminectomy and the approach, of course, for some tumors, not for all kind of tumors, through the hemilaminectomy and the protection of the spinal cord, because the problem is not only the laminectomy, but also the fact that the dura mater opened only laterally protect the spine during tumor removal.
Thank you. Any other comment or questions?
Yeah, can I ask Imad? I want to know what is the venue for an intramedullary tumor?
What is
for an intramedullary tumor when you take a midline in myelotomy and you take a little bit longish myelotomy?
Yeah.
What happens to what is the joint position, sense, affection, and how does it affect the recovery of the patient, and what happens to it in the long-term outcome? what happens, whether the joint position sense is troublesome to the patient or not? What is your experience in this?
But for some patients, for example, the first patient I presented, the patient had a severe tetraparesis before operation, and but she recovered. I forgot to mention she recovered, slightly recovered after a long rehabilitation. I think that the problem is we know exactly at all that the injury of spinal cord is the tumor itself. In many cases, the spinal cord is only very small tissue. So I think that myelotomy, midline myelotomy, in my opinion, does not produce additional injury, because if you find the plane, the dissection plane between tumor and the spinal cord, probably you can be successful. It depends, of course, on the preoperative state, neurological status, and the duration of the neurological deficits, because when you have a patient with long-lasting preoperative neurological deficits, the results, as you know, after operation are not so good. This is, but why are not so good? Because the spinal cord was damaged by compression of these tumors.
You mentioned something interesting. Sorry, Vladimir, just to continue on this one, I'll leave it to you then. You mentioned some technique which sometimes I use, and it was mentioned by you about the segmental incision, that you take an incision and then you leave an area where you see vascularity. You don't want to cross it. Even in the midline, usually less vascular, but sometimes the vessel cross. So you do another incision below that and you try to connect from underneath. Do you think this is valid? Because I like it, because sometimes.
Yeah. I mentioned it just because I use it in some cases, and the damage to the columns, if you go through the sulcus, are not so great, because and it's important to use this approach for laterally located, but sometimes when you have a large tumor, we can use also this route to remove the tumor.
Vladimir?
Yeah, it's only the remark on terminology. We all are using the term myelotomy, which it is not. Sharply, we cut only the ependyma. It's ependymotomy. And then it's blunt dissection along the midline as long as the tumor goes. So myelotomy is not the proper term. We should be using ependymotomy only.
I agree with you, Vladimir, but as you know, it was used for a long time. So just to understand each other, but I completely agree with you.
Any other comment or questions? Thank you, Frank, again for this, Francisco, for this presentation. So we'll move to the last presentation on that session. Will be by Professor Lucas Rasulik. He is the chief in Belgrade University. He is heading the section on the peripheral nerves, and he is involved in a lot of conferences, and he will be talking about teaching perspective in peripheral nerve surgery. Lucas?
Thank you. Thank you, Imad. Can you hear me? Yeah.
Yes.
Oh, yeah.
Thank you, Imad. Good day, everybody from Maastricht. I'm actually in Maastricht in IANS training course, which is regular activities in education within the IANS, and we are in photo finish of preparation for the IANS Congress in Belgrade, which will be in October next year. I congratulate to Imad and Vladimir for this excellent initiative, especially for the idea to honor the distinguished neurosurgeons whose achievements are staying as a legacy within the world neurosurgery. And this is respectfully to Professor Basso. I have a privilege to collaborate with him in many aspects, but generally speaking, especially within the peripheral neurosurgery committee in WFNS and during all these activities, which are well known, he gave a very clear vision about peripheral neurosurgery. He's giving a very clear vision about peripheral neurosurgery, and that's why we appreciate his support very much among all other activities. This is, I don't have anything to disclose. As you know, this is a global neurosurgical workforce. We need more neurosurgeons all over the world. We are now devoted to the global and neurosurgery and global humanitarian activities all over the world, especially in Africa. And IANS is working very hard on this in terms of preparing everything what is necessary to improve the education of African neurosurgeons and give a contribution to all previous activities what have been done, as we know very well whatever have been achieved during the WFNS. This is the learning pyramid in general in neurosurgery as well as in peripheral neurosurgery. So this is a time-consuming process, and you have to give a product to the community, which is a very well trained neurosurgeon. These are geographical specificities which are influenced in teaching perspectives within the education in peripheral neurosurgery. As you can see, there are geographical differences in different parts of the world who is doing peripheral neurosurgery. And this is, let's say, borderline, no man's land between the orthopedics, plastic surgeons and neurosurgeons. True meaning of this education is that it must be interdisciplinary, taking care about the geographical specificities. We have to train our young neurosurgeons that meticulous exam preoperatively and postoperatively by the surgeon is mandatory and condition sine qua non. And studying individual cases has more value than cohort studies, which is very well known. We have to develop tolerance towards diversity, ability to look things differently, and accumulating experience by applying well thought over strategies. And there is no good surgeon out of the operation theater, so we have to be in the operation theater to expose and to give a lot of efforts in this surgery. This is my favorite two slides. This one is Earth 5.0. This is what we are striving for and where the world is going on in the future. This is already 5.0 version, and book in which you can see everything like this. For example, this is also one of my favorite. Could machine replace the man, and what will happen with the man? This is a machine which is doing this by itself. This is not the man beside the machine. So this is a pre-programmed machine doing this, and this is something what is necessary to be included in education in every field of neurosurgery, and then in a peripheral neurosurgery. So this is something what young generation must include in their education. And frontal lessons with some hands-on and cadaver labs, stimulation, web access, or by ad hoc committees. This is the classic format of teaching in current state of educational activities. This is a well-known slide that by PowerPoint, which is trying to be avoided. Interactive communication between faculty participants, discussion groups, breakout sessions, and hands-on activities are nowadays very important. Miguel mentioned Professor Basso and his activities in WFNS Foundation. WFNS Foundation made a lot of efforts in providing instruments and all support in training centers program all over the world, which peripheral neurosurgery should be included much more. And these are some of the full program training centers in the world so far. There are much more many now in develop progress. These are some milestones for some neurosurgeons somewhere in the world. This is according to the brain surgery, also related to the brain surgery. This is also the same situation with the peripheral neurosurgery. And I have a lot of requests from the people from especially Africa to come in some of the centers of for education in peripheral neurosurgery, since there are only one or two or three of them in a huge community doing peripheral neurosurgery. Communication is very important, and this is something what we are also doing in everyday activities. Nowadays, we are facing the digital education, and this is an emerging tool for contributing the information in neurosurgical communities. One of these platforms is a Zoom platform, as we know. These are some of the possibilities in education, hybrid trainings, all other, let's say, platforms for education within the actual technological achievements, education via simulation. You have now augmented reality, artificial intelligence, lot of activities which are included. This is one which is now very in well progress, developing excellent models such as models in all fields of neurosurgery, pathological models for training. This is so-called DAP surgeon, and within the 3D anatomy series. But the weakness of the internet tunneling is that there is no quality of control in some sites, and every surgical approach can be posted, even if it requires a long training curve. Need for a place for where to display approved guidelines and procedure, and this is something that we have to fight even more for that. The use of web technologies, telemedicine, even by phone for a consultation, novel guidelines for patient transfer and responsibility and control for the referral neurosurgical centers are also in this matter. But what is the reality? This is a basic or essence of the neurosurgery. Keep it simple, surgeon. So we should cover simply clinical history and exam, keep the indication simply, make the surgery simple, avoid complication, and neurosurgery can be done with the simple basic instruments, and you have complication, accept it and deal with this. These are the tasks that the group of devoted neurosurgeons all over the world developed and put in front of themselves, creating a special task force group for education all over worldwide, especially for the low and middle income countries, in order to promote peripheral neurosurgery, to improve the quality of education. As you can see, this is basic set for cranial surgery and spine surgery, and this is basic set for peripheral neurosurgery. So peripheral neurosurgery can be done with also with very simple instruments: magnification for cranial and spinal, and for peripheral nerve. So you can have also monitoring cranial, spinal, and peripheral nerve. So you can have let's say, enough for start to be educated in peripheral neurosurgery, including all other aspects of education, starting from the anatomy and surgical approaches, and the physiology and pathophysiology, and understanding of regenerational process. And peripheral neurosurgery is not limited by technology. You cannot expect that somebody can have something what you will see in the presentation in the next few slides about actual achievements in the technology worldwide, which are also implemented in peripheral neurosurgery. And this is something which is current standards in peripheral neurosurgery. This is direct suturing, stump coaptation, and nerve grafting in a clear indication. When you have a clear indication for this, with vascularized and non-vascularized graft, this is something what can be done with the simple instruments. This is interfascicular grafting, just showing you examples of how it can be done with the with simple instruments and basic magnification. This is a nice example of the interfascicular nerve grafting, which is very efficient. Also, cable grafting, modified cable grafting are also on disposal for these circumstances. These are examples of the cable grafting, and in nerve repair, in the reconstruction of the nerve gaps and the deficit of the nerve tissue. These are some of the examples of the reconstruction of the sciatic nerve with tibial and peroneal component using modification of the cable grafts. There are also difference in techniques in terms of using suture or using only fibrin glue. We are using always both in terms of stabilization of the suture line. And another development right now is using tubes or conduits in nerve grafting instead of auto transplantation, such as sural nerve as usual. This is also a very nice development, but clear indication for this. These are the portfolio for nerve repair solution in artificial grafts in actual circumstances. But now we are going to back to the future. This is a robotic surgery. So robotic surgery and peripheral nerve surgery starting first on cadavers, and this is something which is already developed. This is how it looks on cadavers, and on cadavers it has been achieved that you have a nice visualization. You have a space for exploration, for identification of nerve elements, even for suturing. And this was completely demonstrated using Da Vinci robot, and this is a nerve grafting in a C5 elements of the brachial plexus. And then in future perspectives, future developments understand the use of additional technologies and implement the new knowledges about in biology and microbiology in terms of how to make augmentation of the nerve regeneration. These are some of the options which are also included in this, such as usage of Schwann cells, transplantation of the olfactory and sheathing cells for peripheral nerve regeneration, then stem cells for peripheral nerve repair, and then gene therapy, and then phototherapy. This is something which is also very, very let's say active now, augmenting nerve regeneration with electrical stimulation. This is very important for the nerve regeneration. Also, we are using some pharmacological agents for nerve regeneration in order to improve this. Endoscopic surgery is also in progress within the peripheral nerve surgery. Beside the carpal tunnel and the cubital tunnel, which are classical endoscopical dissection in peripheral nerve surgery, this is supraclavicular plexus dissection using instruments and scope configuration. And this is something which is also in development. This is a endoscopic and open topography root dissection in exposure of the all brachial plexus supraclavicular elements, C5, C6, C7, and nice exposure. In clinical practice, Brazilian group of neurosurgeons already implemented this robotic surgery, providing the patients overland procedure with the Da Vinci S robot for restoration of the elbow flexion, and SOMSAC procedure for restoration of the arm abduction. And this they report the nice results in a small series, but nice results in these circumstances with a good functional recovery. Artificial intelligence is also in everyday practice in terms of preparing nerve graft selection for peripheral nerve regeneration using neural networks. This is especially important for prosthesis, which is also in the everyday practice using this network controller algorithm. And this is all, let's say, on disposal for surgical treatment strategy decision-making process. But even now, even today, we are still in the situation that we are have to choose between the class 1 evidence based on preoperative evaluation, which are we lacking, and then coin flip based decision-making as a matter of interoperative finding and surgical experience. This is something what is really actual. So cutting your nerve changes your brain. When your nerve is injured, your brain is suffering also, but your brain is doing something which is named brain plasticity, in terms of when you obtain a nerve repair and nerve regeneration, especially when you perform nerve transfers in the brachial plexus reconstruction, you have a brain plasticity as a phenomenon in terms of helping the better results in reconstruction surgery. Quality of life is mandatory, and the quality of life in peripheral neurosurgery is very important. Beyond useful functional recovery, there are a lot of issues in let's say a relatively small number of publications which are understanding all these issues which are necessary for the quality of life of this patient. And before the conclusion, solving controversies and dilemmas in peripheral neurosurgery depends on the surgeon, his choice of methods and experience. Treatment should not be worse than the disease itself, and for the one who has nothing, a little is lot. All these problems are now important for the relation of this patient in terms of his improving his quality of life. In perspective, these are some perspectives of peripheral neurosurgery, what we have to, let's say, improve in terms of this double nerve transfer for shoulder function, double nerve transfers for elbow flexion, combined nerve transfer with separation of fascicular groups, treatment of long-standing brachial plexus lesion, and treatment of older patients. In further perspectives, cellular surgery concept, pharmacological activation of regeneration, nerve elongation, non-neural tubes, and non-suture techniques, and nerve anastomosis. Within the limitation, we cannot be quite satisfied with the recovery if the patient itself is not. And in these perspectives, technological achievements and scientific achievements, it will, let's say, contribute to this. In my opinion, class 1 evidence-based strategies are still a matter of further double-blind randomized cohort multicentric control studies, including especially new technological achievements. Surgeon decision based on a knowledge and experience is a predominant impact factor, and hand of the surgeon will still be irreplaceable impact factor, despite how one would like in a 21st century in peripheral neurosurgery. These are some famous persons who suffer of injuries of the peripheral nerves and then recover functional completely. This is for the end just some photos from our previous period in education and transdisciplinarity all over the world, what was achieved during past, let's say, 10 years in all aspects of education, including online at that time. And as you can see, we are very much involved in all neurosurgical activities, following all neurosurgical major events, and trying to improve these activities in the best possible way. And this is the course where we were together in Buenos Aires and Argentina with Professor Armando Basso. This is something then after that COVID-19 stops, and now we are continuing with first joint flank and IANS theoretical practical course on peripheral nerves and brachial plexus surgery, which will be held in Rio de Janeiro in April next March and April. And forthcoming courses will be in the Rovigo, Italy, and Dubai, United Arab Emirates. These perspectives is all the demands. We have to also learn to push our colleagues to publish and to encourage them to publish their results even in a small series. And this is all important because this is something what is necessary. So in conclusion, hands-on courses, on-site training with the functional support and foundation of the continental national societies and basic activities should build up a bridge between countries, more than countries with less resources. This is one case of schwannoma operated by me. You can say that ulnar nerve schwannoma is an easy case, but for the fine movements of that lady who's playing this flute these extremely five movements are of the outstanding importance. So this is something what is also necessary to be developed in education processes. So thank you very much. I cordially invite you in Belgrade for the forthcoming IANS Congress. You know everything about that. IANA will be present in very first day of the Congress and all other activities. We have a annual meeting of Serbian Neurosurgical Society in December. You are more than welcome to join us, and thank you very much for your attention.
Thank you, Lucas, for this very organized presentation and building the future of peripheral nerve neurosurgery. And I like the conclusion music, and I wish I could play it even with my full fingers without ulnar nerve. This kind of music, wonderful. Any questions or comment? Francisco, unmute yourself.
Excuse me. Thank you so much. Lucas, my sincere congratulations for this overview of innovations in peripheral nerve surgery. And also, my congratulations for your efforts for education around the world. I would like to ask to you about the stem cells. You mentioned the stem cells. I know that orthopedic surgeons use more and more in recent times the stem cells. Can you tell me, are there some trials for the use of stem cells in peripheral nerve surgery? This is interesting for me.
Yes, Francesco, thank you very much. This is something that when I present, for example, case series presentation in the peripheral nerve surgery within the brain giants and the brain neurosurgeon giants and the spine neurosurgeon giants, it might be boring. You understand me? That's why I'm trying to make some kind of interesting presentation, which might be, let's say, increase the intention of or in some progress. Generally speaking, the question is very important. Not only stem cells, but stem cells particularly, but all other things are now mixing in clinical stages of evaluation, different stages of evaluation, using special matrices, which you put in, let's say, make an infusion of stem cells and use that matrix and then put around the nerve transplant, because you have to have nerve transplant. You understand? You cannot have a artificial, although there are cadaveric transplants. Even in that, some of these additional resources are using to, let's say, stimulate and initiate and augmentate regeneration. Stem cells, there is a nice experience so far, but still have some clearance in a clinical phase 4 to see, to let's say, to evaluate how important is the influence of the stem cells. I mean, their influence is evidence, but is it crucial or not? Should we put to every patient, to every graft, stem cells or not? What about when there are no possibility to use stem cells in the different centers? So this is very difficult to standardize in these circumstances. But very good question. I mean, there is nice experience with the stem cells so far.
Thank you.
Thank you. Any other comment or questions? So we are perhaps ready for the next session. We'll be chaired with my colleague and friend, Professor Vladimir Benish. Thank you, Lucas.
Sorry, I don't want to say goodbye to you. I have to go to chair a breakout session here and in this course. But I don't want to say goodbye. I want to say see you in Belgrade soon.
Hopefully, yes. Say hi to the group there. Okay.
All the best.
Thank you.
Bye. Thank you.
And the next session will be chaired by Professor Vladimir Benish and Professor Ramesh, who has a lecture, but he has to take a flight as well. That's why he doesn't want to be staying all the time. And I don't know whether Professor Roy Daniel will be here to replace him because he has a lecture. Otherwise, I will be with you, Vladimir, but not to the last. I have to catch up with my family. They are waiting for me somewhere in a shopping mall in Turkey. And okay. But before I give this over, I just want to welcome our colleague, Professor Juan Ruiz Gomez Amador. He's first time with us. He is a professor of neurosurgery, and he is director of skull base and endoscopy service at the International Institute for Neurology and Neurosurgery, but I could not figure what is MV. Is Mexican University? That's what it is?
No, Professor, it is the name of our founder, Manuel Velasco Suarez.
Oh, okay. And Professor Juan, he is president now of the chair of the Neuroanatomy by the World Federation. He is our successor for me and Vladimir. Welcome and thanks for accepting the invitation. I'll give over to Professor Vladimir for his moderation.
Okay, thank you, Imad. You already have said that we shall have a little change in the program, that Ramesh Schneider has a plane to catch. As I see today, everyone has to leave early. I shall have a problem since it's my wife's birthday and we have a party. So I hope that we all shall keep on time. We are already running some 45 minutes late. So I would urge all the presenters to keep on time. So the first lecture will be Ramesh, and then we shall go as it's put on the program. Ramesh, please.
Yeah, thank you, Vladimir and Imad, and also for my speakers in line for letting me go first. It's just that I'm going to Malaysia for a conference, and the flight is in 2 hours' time, so already running late. I just wanted to give some of my viewpoints regarding how to select the adjunctive treatment when you treat arterial venous malformations of the brain, which is our topic for in the second session. As you know, whether to treat the cerebral AVMs or not is often discussed, especially in an era where there are some studies showing that it may be better treated conservatively, at least in asymptomatic patients. But as you know, the majority of AVMs at some point, especially in young patients, will become symptomatic. And those become symptomatic. They become symptomatic with the hemorrhage. And as you know, the morbidity or mortality related to a hemorrhage from an AVM is quite substantial. It's somewhere around, it can range from various papers have shown that it could range from 15 to 40%. So it's quite high percentage. And when we talk about surgery, I will talk about some of the choices we make, whether to use the adjunctive treatment before you operate on this patient. So I'm purely talking on the surgical patients. When do you want to embolize this patient, whether you want to embolize or not, that's another question. And also, when do you want to use radiosurgery for treated AVMs after surgery? And also, in rare occasion, you could also do surgery when a failed radiosurgical patient. And I'll go through some of the cases just to establish the points. This is someone who's in his 50s, came in 2019 with a small stroke over the right temporal lobe, and he was found to have a vein of Labatt thrombosis on that side. And there was some abnormality around the frontal lobe, and he seemed to have significant congested brain. So he had a multitude of problems. He has got a venous sinus thrombosis, and sagittal sinus thrombosis. The sagittal sinus was thrombosed, his vein of Labatt was thrombosed, and he had a big AVM on the frontal lobe. Obviously, this was a high flow AVM with multiple feeders, mostly from the internal circulation, but also there are from meningeal circulation, including some of the meningeal supply from the ophthalmic and some of the branches from the internal carotid. You can see that in this angiogram. He has a significant supply from the anterior circulation and with a feeder aneurysm at the base of the anterior communicating artery. So this was quite a large flow AVM where he had a significant shunting. However, while he recovered from the stroke and while waiting for consultation, he came back almost about a year and a half later with subarachnoid hemorrhage. He remained grade 1, and we went through further investigation, including the full workup, which confirmed the presence of a large AVM of the frontal lobe. You can see the significant venous congestion related to sinus thrombosis, along with this shunting through the AVM. So when do you want to embolize this patient? Whether you can embolize this pre-surgically, when you talk about the interventional radiology approach, you could embolize them pre-surgically, you could embolize them before radiation treatment in some cases to reduce the nodal size, to make it more amenable to radiation treatment. And in many cases, it may be curative, but the number of cases in which the interventional endovascular embolization is curative is fairly low. We know that, especially it may be useful in small cases, small AVMs, and in many cases could be just palliative. But when do you embolize? Do you need to embolize these cases when they are low flowing AVMs, low grade AVMs? And if you have a larger AVM, do you stage it or use it in single session? So most often it may be an appropriate thing to stage the embolization if you're planning on elective unruptured AVMs. And what we have to consider is the fact that it is not without risk. You are already approaching this case for a surgical excision of the AVM, and why do you want to add the additional element of risk of interventional approach to this AVM? So this is the risk we have to analyze. So this is quite a delicate balance when you want to decide whether to embolize or not. I feel that whenever there is a high flow fistula and there is a significant shunting with a significant pressure within the whole nidus, it may be appropriate to try and embolize the fistula and then reduce the flow. That will make your surgery more easy or more less stressful. And whenever you have a ruptured perinodal aneurysm, it may be a good practice, if it's possible, to embolize it so that you don't have any disasters during surgery. As you know, they are very fragile aneurysms, and with the serial monitoring, many of these aneurysms do expand without treatment. And if you have a patient who has got a significant hemorrhage, and if you have a feeder ending up in the AVM or supplying that part of the damaged brain, it may be possible to treat or embolize that feeder. And often in those situations, especially with the shunting from a high flow fistula, you may want to coil it rather than using embolic agents, in which case the embolic agent could fly off into the venous system to cause a venous thrombosis and a perioperative hemorrhage. So this man, sorry, let me just try. Okay, this man had multiple investigations, including angiograms, and he went for one of the embolization for one of the branches, which substantially reduced part of the AVM. So this was mainly to reduce the pressure within the AVM nidus prior to an operation. You can see the sagittal sinus is thrombosed in the posterior part. And he also had external carotid supply through the meningeal artery coming to the forks, supplying the AVM. So this was a complex AVM. But such nidus, this is an interhemispheric approach. That nidus, which is supplied by the meningeal branch, it could be easily accessed through the meningeal supply. On this one, you may not be able to access it through an endovascular route to coming all the way to the nidal point. You can embolize it very proximally, but that's not of much use. So here you can go to the interhemispheric fissure, find that feeder and ligate it. So we'll skip this surgical aspect of it. This is the part of the AVM which is embolized. You can see they use something called a film, which will give you a white color within the embolized vessels. And there are some cortical veins running through in front of the AVM to the sagittal sinus. So these are veins which are mixing the venous flow along with the arterial blood. So this is the way the AVM is dissected. We will skip the surgical aspect of it. As I mentioned, he did have an aneurysm as well, where that ACOM aneurysm was quite wide-necked, and it was not suitable for endovascular treatment. And it wasn't certain whether he bled from the AVM when he came back with the subarachnoid hemorrhage or whether he bled from the aneurysm. So in the end, after resection of the AVM from the parasagittal area, you have a long route to reach to the ACOM region. But that was the procedure he had. After excision of the AVM, it's the superior hemispheric approach to the aneurysm, but it was not ruptured, and that was successfully eliminated. And you can see the post-operative angiogram showing complete resolution of the AVM. A similar technique, similar strategy in posterior fossa AVM, for example, when you have an AVM supply from multiple feeders, from the pica or the ICA or the superior cerebral artery, from a surgeon's surgical perspective, one could go and attack the pica supply directly from a surgical exposure, including the aneurysms of the pica, feeder aneurysms of the pica. But the aneurysm, but the feeders coming from the superior cerebellar or anterior cerebellar are much more anterior. So if there is an option to embolize those one may want to embolize them. So this is a patient treated several years ago with a large AVM, had a bleed, and we can see several branches coming from the anterior aspect. So once you approach from the posterior aspect, you can disconnect the supply from the pica branches, including the aneurysm, which you can remove surgically. But if it is possible to embolize them from the front, that would be the best solution. So he did have embolization from the anterior aspect to reduce the flow so that's the portion of the AVM you will reach last. So it makes sense to try and embolize them if possible. And also it may be possible to treat the aneurysms as well. So this is the appearance after the embolization. There's still significant flow in the AVM, which was resected through a surgery. And this is another AVM, but this is again frontal AVM with the intraventricular hemorrhage, with significant feeders coming from the anterior circulation. But in this case, the more anterior feeder almost ending up in an AVM, and I could not really, most of these feeders, you may find that they may not go beyond it, but once you remove the AVM, you may find that they're all on percent vessel. In surgery, you find that you just have to ligate or cut off each feeder by feeder, and then you can follow that normal artery backwards. But in this case, given the high flow, I decided to embolize the anterior branch before removing the AVM. So this is the post-surgical view. And this is another interesting case. A very young lady came with a bleed and was found to have an AVM of the right paracoccipital area and very close to the occipital fibers, visual fibers. And there was a finding of a small perinatal aneurysm, which was right there. And so that was with the monitoring within a couple of days, it's substantially increased in size. And that was beyond the white matter fibers, which is obviously the white matter fibers traveling to the characterizing cortex. So we decided to embolize the part of the pica, the posterior circulation supply, the PCA supply, and also to embolize the aneurysm. So this aneurysm was tackled by endovascular intervention, along with this branch that supplies the posterior aspect of the AVM. So this was the aneurysm, which appeared much bigger compared to the initial angiogram, and that was embolized along with the PCA supply, which you can see in this picture, the part which was embolized. But from a personal perspective, I could have taken the whole PCA supply, but to attack that to the aneurysm, which was much more deeper, traversing the white matter, would have risked some field deficit, which was avoided by doing an interventional approach. So that's the post-operative view. So when not to embolize? So essentially, it's a decision-making based on the risk and benefits. If you feel that adding the intervention risk adds to the overall risk attached to your operation, I think it may not be a worthwhile idea to embolize these patients. In this case, it's a fairly standard AVM with known feeders. Most of them are on the surface. You can see they're all coming from the interhemispheric fissure. One branch is coming and then supplying with two branches, another more anterior branch. So these are all accessible surgically. So this is all, these feeders can be exposed surgically. So one doesn't need to try and embolize these branches, because you can avoid the additional morbidity and mortality related to interventional approach. But in some cases, this is a young nurse who came with a bleed and dysphagia. with a left frontal bleed in the just above ropiculum area with a compact nidus. But you can see that there is an elongated AVM, as most of the AVMs are, with a point towards the central white matter. And what we do recognize is that there are feeders coming from a more proximal location. When we approach this lesion around the AVM, you disconnect all the feeders from here. But the deeper feeder, which is in a much proximal location, it may be very difficult to see it or to expose it. So in which case, there was no option to endovascularly embolize it. So we had to consider. So when I finished, I knew there was some remnant, as you can see, which was in a very deep location, which was in the corona radiator, and she was sent for stereotactic radiosurgery. So these are some occasions where you may not want to re-explore, because you know that it's going to cause additional deficit, and one may have to consider the stereotactic radiosurgery. But obviously, you have to accept the small risk that it could be possible if there is no venous drainage from the small remnant you left behind. Then there is a risk of that it could bleed. So you have to make a decision on a case-by-case basis. So that is what we have to decide: re-exploration versus stereotactic radiosurgery. All these patients get a routine post-operative angiogram, and you'd make a decision whether to do re-exploration immediately or consider a delayed treatment. Because many of these cases, if you see some anomalies in the immediate post-operative angiogram, many of them by the time they go to this stereotactic radiosurgery, the second angiogram often will show resolution of all these anomalies. So that you have to understand. And it is not very a common practice to do surgery after radiosurgery, but it is something needed when you have a failed radiosurgery patient, multiple radiosurgery patient. But often, thankfully, they are less complex because most of the AVM is gone, but there is
Ramesh, we do not hear you, Ramesh. Ramesh disappeared. I guess there was some failure on his side, so let's go on with the program. He's not getting back, and should he get back and should he have time, we probably could have the second part of his lecture later on. Imad, do you agree?
I agree. Let's move to the next.
All right, so let's go for the next. It's Professor Juan Luis Gomez Amador, and it will be about the endoscopic techniques applied to neurovascular pathology. Please.
Thank you very much, Professor Benes. In the first place, I would like to acknowledge the great work that you and Professor Imad Kanan are doing for the neurosurgery worldwide. I think this is one of the great experiences and a very good academic endeavor that provides to all the surgeons in the world different techniques based on the neuroanatomical concepts. I would like also to thank Professor Armando Basso for all the teachings during so many years, and being a director of the Latin American Federation of Neurosurgery, and for his great work in the World Federation of Neurosurgical Societies. So we learned that the endoscope could be applied to microneurosurgical techniques for the treatment of intracranial aneurysms. So we know today that we can perform several different techniques to achieve a good result in neurovascular surgery. For example, the endoscope-assisted neurosurgery, in which we can treat intrinsic and extrinsic tumors, as well as interventricular lesions, but also we can inspect for aneurysms. With the endoscopic port surgery, we can treat intrinsic tumors, metastases, interventricular lesions, but also aneurysms and cavernoma, as we will see later. With the endoscopic intranasal surgery, it is very complex to treat vascular lesions, but we can see that this could be applied for some aneurysms and some cavernoma in specific locations. We know that the basic principle for all these maneuvers is the microsurgical concept that was given to us by Professor Yashargil with the refined and perfection of the microneurosurgical techniques and the development of the specific instruments to treat these lesions. So for this reason, we need to have a very clear understanding of the tridimensional anatomy of a vascular lesion in order to treat it properly. The protocol that we use when we apply the endoscopic techniques to the inspection of the surgical field of an aneurysm, we do primarily the dissection of the aneurysmatic complex. Then we do a pre-clipping endoscopic exploration that allows us to identify properly the perianeurysmatic vessels in order to avoid its obliteration. After the endoscopic exploration, we do the clipping either by the endoscopic assisted or directly with the microscope, and we do an after clipping an endoscopic exploration. So we can have an integral visualization of a perianeurysmatic anatomy under direct vision. This is an example of a very large PCOM aneurysm in which we are dealing with this through a terminal approach. And we insert the endoscope in order to see that our clip is very well placed and there are no branches around the place of the clip. After this, we have a lateral perspective that the microscope cannot give us because we are coming from above. And then after this is completed, then we will proceed to the aneurysmectomy if it proceeds, as in this case, this is a very large aneurysm. This is another case with a rupture anterior communicating arterial aneurysm. We have the endoscopic perspective through the right terminal approach in which we are able to identify properly the clips, the aneurysm and the A1 and bilateral side. So we insert the first clip in the conventional manner through the terminal approach. And we will see that after the clipping of the aneurysm, which is conducted by the vision of the microscope, we will observe that we are producing an occlusion of the distal anterior cerebral artery on the left side. As you can see here, the artery is between the blades of the clip. So we need to remove this clip. And for that reason, we move the endoscope. So as we are facing it, if we are coming through in an interhemispheric approach. So after, under direct visualization, we see the permeability of the vessels around the aneurysm. This patient had also a bleb in the contralateral internal carotid artery that we were able to inspect using the endoscope in the contralateral corridor. We just apply a piece of gauze above this bleb, and then we came to treat the most common aneurysm, the PCOM aneurysm, and in a straight manner. This vision is provided by the endoscope, but we are working with the microscope. So after clipping, we see there is a small remnant of the aneurysm that we were not able to catch with the blades of the clip. So it is mandatory to reapply the clip. And in this case, we use a semicurve clip in order to avoid this small portion of the aneurysm so we can treat it properly and we can save the PCOM. This is the application of the clip. Now we have the entire neck of the aneurysm, and this is a very common case. And in this case, we were leaving a small remnant of the aneurysm that we were able to identify using the endoscope. This is a contralateral aneurysm. We are performing a left terminal approach for an MCA, and in the right MCA, we are able to make the clipping in the M1 segment. So we can appreciate with the endoscope the permeability of this early temporal trunk and the permeability of the M1 segment with complete obliteration of the aneurysm with this fenestrated clip. This is another case for multiple bilateral aneurysms in which we are able to have the complete clipping of the case using a standard right terminal approach. We're performing the enteroclinidectomy. We came to the basal cisterns, and then we opened the left sylvian fissure to identify this aneurysm on the MCA. we perform the clipping, and then we insert the endoscope to see the adequate clipping of the aneurysm with permeability of the vessels. Then we came back to the ACOM complex. We performed the direct clipping under microscopic vision, and again, we insert the endoscope to have a good visualization and complete obliteration of the aneurysm. This patient had also a right PCOM aneurysm, which was also clipped in the same manner. There is no big deal in this case. And then we came to treat an MCA aneurysm located in the right side. This is another case for bilateral PCOM aneurysms. As you can see here in the preparative angiogram, we come in front of the optic nerve. We conduct the clipping of the contralateral PCOM and the ipsilateral PCOM aneurysms, and then we insert the endoscope to have a proper visualization and preservation of the vessels, as you can see here in the postoperative angiogram. Another case for the use of the endoscopic techniques is the treatment of intrinsic lesions. We learned that the fiber dissection technique with Professor Touré and Professor Polo Kadri, that we can treat lesions located very deep in the central nervous system. As you can see here, 3 examples. One, mesencephalic cavernoma treated by the left pterional transylvian transinsular transchoroidal fissure approach, which today I will do this case using the Touré's technique, using the supracerebellar transcentorial approach. Another case for a left thalamic lesion, or a case for a pontine lesion treated with the superior median suboccipital supracerebellar approach. What else can we do? We can use the endoscopic port. In the beginning, we use this artisanal device. Now we are using these retractors to insert the port and treat lesions. We start to treat lesions in the cerebral parenchyma for the cases of metastasis, and also for extrinsic lesions, as we published just recently, using this endoport to treat the dorsal portion of a pituitary adenoma, very large pituitary adenoma that invades the ventricular system. The technique is very simple. We perform just a small craniotomy, 2 by 3 centimeters. We insert the endoport guided with navigation. And once we sit above the lesion, then we can treat it, as you can see here in this tape, in which we are able to use both hands and using large instruments that we insert through the port, so we can displace the white matter fibers in order to achieve a complete resection of the lesion, as you can see here. This was the case of a frontal cavernoma, and as you can see, yes, in the postoperative MRI, we achieve a complete resection of the lesion. This is the trajectory of the port. This is a very early MRI in which we appreciate this trajectory that later disappears once the fibers took its normal place. This is another case, temporal cavernoma. We insert the port, and once we stay in front of the lesion, we are able to identify the pericavernoma hematoma, and then we open the cavity so we can take the internal portion of the cavernoma and then to treat the active portion of the cavernoma so we can achieve a good result. As you can see in the postoperative MRI, there is complete resection of the lesion using this endoscopic technique. We can use the microscope with the port, of course. This is just an alternative to have a direct vision of the surgical field that is located deep in the surgical field. Another case, this is a very spectacular case, a very unusual case, a patient with a subarachnoid hemorrhage, with a parenchymal hemorrhage and an intraventricular hematoma due to a rupture P3, P4, PCA aneurysm. So we insert the endoscopic port, and then we were able to deal with the aneurysm. We performed the direct clipping and aneurysmectomy of the case, and this is the postoperative angiotac, so we can see adequate result of the case. When we deal with the intraventricular endoscopy, sometimes we feel that we are trapped inside the canal, the work channels of the endoscope. So we prefer sometimes to use the port in order to feel more free in our surgical field. This is a case that we treat with the endoscopy. This patient had an intraventricular hemorrhage due to a lesion that is located just in the superior part of the aqueduct. So we use the endoscopic technique to reach that lesion and take it piece by piece and make an adequate permeabilization of the interventricular system so the patient had a good result with no hydrocephalus in the postoperative period. I will stop to share my presentation in order to resolve a problem with the computer that is blocked. But the point is that we can use this interventricular endoscopy to treat very selected lesions when we are dealing with vascular lesions. For some tumors, we can use the ultrasonic aspirator through the work channels of the endoscope, and this is a very good technique in order to achieve a good result. But always we need to see what the patient needs. Not all the times we can use the endoscope to treat some lesions, as you will see later. For the case in this patient, the result was adequate, and we were able to perform the complete resection of the lesion with no harm for the patient. So, as you can see here, the patient in the postoperative period is in good clinical conditions, and the
Abra y cierra las manos.
MRI shows complete resection.
Listo, bájalas.
Now, we will move endoscopic endonasal techniques that we can apply for neurovascular lesions. And these are very complex lesions that we are able to treat if we select properly the case. So for some time, we have dealt with lesions in the endoscopic endonasal techniques, and we are able to see the arterial vessels. In this case, for example, for a craniopharyngioma, we are able to see the anterior communicating artery complex. We can see also the internal carotid artery in the cavernous sinus. Sometimes we deal with the carotid artery when we are treating some pituitary adenomas, as in this fibrous case, in which we need to come from the sella turcica and also from the lateral portion to the cavernous sinus in order to treat this lesion. And this allows us to think, if we are able to see the vascular structures, we can treat vascular lesions. Some guys propose the treatment of, for example, for anterior communicating artery complex aneurysm using these endoscopic endonasal techniques. We don't think this is a good technique to be applied for this vascular lesion because the approach is very complex and the complications as the CSF fistula are very important. So it is not wise to do this approach for these specific lesions. But for some other locations, as the paraclinoidal internal carotid artery aneurysms, for some cases that are projected medially, this endoscopic endonasal transtubercular approach provides the surgeon a direct vision of the medial portion of the internal carotid artery that can be treated adequately with a straight clipping, as we will see later on. And also the endoscopic endonasal techniques have a major role in treating some ventral lesions of the pons. And this is because we are able to identify properly the ventral pons area, so we can treat properly the lesion using an endoscopic endonasal approach. So I will skip some of the slides due to the time, but I want to show you some cases where we are able to treat vascular lesions, as in this case, located in the posterior fossa, a very large mid-basilar giant thrombosed aneurysm, in which we came using the endoscopic endonasal technique to make an internal decompression of the interneurysmatic thrombus in order to relieve the compression of the brainstem. Later, we closed the already treated sac in order to have a good result with this patient. So we can use also the hybrid suite to treat some of these lesions. And I just like to share with you some of our cases using the endoscopic endonasal technique to treat lesions located in the internal carotid artery and also in the ventral pons. But we need to be very humble and to decide this approach when the patient is going to really benefit from this technique, and not just because we want to do a novel approach, because we can harm the patient, and this is not the case for these techniques. When we are using endoscopic endonasal techniques, we need to be very careful to perform an adequate reconstruction of the defect that we are leaving in the posterior fossa in order to avoid the CSF fistula. In the case for these cases, we can account up to 30% of complications due to the CSF fistula. This is the case of the aneurysm, medially projected aneurysm in the internal carotid artery. We use a balloon control in the internal carotid artery. We perform an adequate exposure of internal carotid artery, the aneurysm neck, above the pituitary gland and below the optic nerve. So we come and we perform the direct clipping using what we call the road mapping technique guidance for the clip. And at the same time, we perform the immediate angiogram in order to achieve a good occlusion of the aneurysm. As you can see here in the postoperative angiogram, there is a good resolution of the case. Finally, I would like to present you with this case. This is one of two cases that we have with ventral pontine lesions. This was a female of 27 years old with acute headache, left hemiparesis, and left hemi anesthesia. So we choose this transclival endoscopic endonasal approach after careful hemostasis of the basilar plexus using hemostatic sponges and bipolar coagulation. We identify the basilar artery. We identify with navigation our entry point. We perform the initial decompression of the hematoma, and then we can treat the active portion of the cavernoma using both hands, using forceps and careful dissection of the peripheral part of the lesion. And we are able to perform the complete resection of this lesion. The alternative is a very complex, probably complex transpetrous approach. But this is just a very straightforward approach that allows us to perform adequate resection of the lesion with no harm of the neurovascular structures around, because the tumor projected, in this case the cavernoma projected at the ventral surface of the pons. Careful reconstruction in a multi-layer fashion provides us an adequate closure of the defect. So I think that these techniques require laboratory training, using the tactile perception, using both hands in the surgical field, and we can treat aneurysm using these endoscopic techniques, but we require a huge experience in microvascular neurosurgery as well as in the endoscopic techniques. More important is the precise clinical judgment, and for some particular cases, we can use the hybrid or OR that allows an integral treatment. And also for the treatment of ventral pontine lesions, we should reserve these for very selected cases in order to achieve good clinical results. And thank you very much.
Thank you very much. There is a question on a chat. How do you deal with aneurysm rupture when you are there with an endoscope?
Yeah. I didn't show you, but the experience worldwide is very, very low. There are only 40 cases reported using these endoscopic endonasal techniques. We have not had the interpretive rupture. For the case that we had treated with the endoscopic endonasal technique that I showed you in the videotape, we use a proximal balloon through the endovascular technique in order to achieve the proximal control. And the distal control was of us after the aneurysm. We could have a temporary clipping in combination with the occlusion balloon by the endovascular.
Okay, thank you. Any other questions? Miguel?
Thank you very much. Just to congratulate Professor Gomez Amador, for the beautiful presentation and for showing, the outstanding possibilities of the endoscopic endonasal approaches for vascular pathologies. Congratulations, Juan Luis. Very good job.
Thank you very much. Thank you very much, Professor Rice. I appreciate it.
Yeah, that was really great. Thank you very much. Someone else? If not, I shall share the screen with you. Is it properly seen or is it?
You are on. You are on, I think.
Is it all right? Okay, I'm going to talk on AVM, how, when, and why. I have no conflict of interest, and I will start. This is a outline of the lecture on how I do it. It's more or less technical. Then I will show you shortly our departmental series over the past 20 years, and then meta-analysis of the relevant literature of all the techniques which are used in AVMs. There are 23 points which I have put together over the years about the technical steps, and I will only go through those which are highlighted because those I consider really important. And the approach, try to position the patient and your craniotomy in a way to have a nidus at the top of the craniotomy and on the surface. Try to approach the AVM nidus along the long axis of the nidus, and if possible, do have this approach vertical, since this really helps you and this is very ergonomic. Large enough craniotomy, I don't need to elaborate on that, well beyond the nidus margins. Open dura carefully. First point which I feel is important, because there are frequent adhesions between the nidus and the dura, and if you would be opening the dura the same way, reflecting the flap in the same way as in the humor, you might tear these adhesions, you might open the vessel, and your surgery would be rather fast over. So let's show you what I mean. The AVM, here is the dural flap. See,
Vladimir, could you put on the screen show?
I did. So let's try some other.
We're not seeing.
This is only in the part, Roy.
We're not seeing the screen show.
You don't?
No.
So let me try it this way. This is the problem I'm having lately. What about now? Is it okay?
Not yet, but that's the right button.
On my screen, it's all right. So I don't know what else could I do. This is now it's not all right yet.
No, not yet.
No, we don't see the full screen.
You don't see the full screen?
No.
I have no other means, and I don't know about some other means how to make it better.
Unshare and reshare.
Vladimir, you have to click on the icon of the full screen of.
Oh, I did, and on my
PowerPoint.
screen, it's full screen. I have had this problem.
Okay.
I really had this problem. So share again. What about now? Is it all right?
No, we are seeing the full spectrum of videos.
Full
and
presentation, and on my screen, this is like. It should.
IANA. Click on it again.
I'm trying. More reasons to hide the video. Now I cannot even leave the presentation. So I really am at a loss. I I don't know what to do. New share. Let's try new share.
Vladimir, you
Yes,
want
sir.
to try now?
I'm trying. I'm doing my best. Now it will go to full presentation again. Do you see the respective slides now?
Yes, we see slides, but
Now I have the full screen on my computer.
it's not transferring.
It's not transferring. Why don't we go to the next lecture and I shall try to learn how to do that, because I don't know any other possibility.
Okay.
Okay.
Let me
Okay,
see.
Just stop sharing. I'm sorry for that, but this happened to me last several times and I don't know how to manage this.
Roy is with us. You want to start presenting the next speaker, Roy?
yes. The next speaker is Professor Atul Goel, who will speak to us on the management strategy for AVMs. Atul, are you there?
Yeah. So can you see my slide?
Yes, I can.
Atul, you don't need presentation because you are world famous now. Already
Okay.
Atul Goel on the webinars.
Okay, thank you, Imad, for inviting me to such an important show of neurosurgery, which is becoming more and more popular, and it is indeed my great honor. And today, I have decided to talk to you on large arteriovenous malformations. According to me, arteriovenous malformation surgery is the absolute last chapter of neurosurgery. It is not just the technique. It is not just the anatomy. It is the philosophy. Most important is to understand your own caliber of neurosurgery, to understand your own talents, understand your own operative skills, because surgery is difficult. Surgery can be absolutely difficult. Surgery can be dangerous for the patient and for the surgeon. And these are benign lesions you must know when to do and when not to do. And most importantly, surgery is the only validated and proven treatment strategy for AVM. So if you can do it, you cure the person. If you cannot do it, don't do it. So my treatment strategy for AVM is either there is no treatment, you just leave the patient, or you resect this lesion. Now, whether you can resect or not resect, that you have to evaluate with your own experience and with your own, understanding clearly, because it is not easy. And if you take any wrong decision before the operation, yes, I can do it, because here there will be no ego working, no overconfidence working, no style working, nothing will work except your experience, your talent. So you have to understand
Eva, estoy intentando reclutar a todo el
what
equipo
kind
porque
of
va a ser una
AVM it
operación
is and
bastante
whether
más
it is
complicada de
surgically
lo que parecía
resectable
hace
or
un
not.
minuto.
So the nidus is very important. Nidus, it can be a small nidus, but it is on the motor strip. One must remember that AVMs are
Pero estoy
subarachnoid
en el
structures.
chasis.
AVMs are not intracerebral, but they can involve the brain by pressure and by invasion. But essentially they are subarachnoid. So this AVM is small, but it is in the motor area. This AVM is a little bit large, but it is in the frontal area. This AVM is large, but has intranidal aneurysm, feeding vessel aneurysm. So it is a high flow AVM. It is absolutely important and critical to understand which AVMs are high flow, because these will bleed quite furiously. So when there is aneurysm present, when there are large vessels present, when there are feeding intranidal aneurysm, when there are large veins, when the patient presents with severe headache, when the patient presents with bleed, and there are various characteristics which show that the AVM is high flow. And we have to know that before operation. I like to see the angiogram before surgery and seeing it being done. So you can actually assess the flow of the AVM, in which direction you have to go and how you have to go. This kind of AVM some of these AVMs should not be touched. Obviously, this is an AVM where you can just leave it on his natural history. You don't want to demolish the person. This nidus was a little bit peculiar with 2 nidus, which is very unusual for AVM, but these are AVM fed by large vessels are high flow. AVM fed by small vessels are relatively low flow. AVMs drained by one vessel is relatively low flow. AVM drained by multiple veins are high flow. So these are the issues that we have to know. So I made my own grading style for AVMs, and this was surgical. When I see the AVM, when I see the patient, I assess. Yes, it is easy. Nothing is easy but for classification. Then I assess whether it is difficult but safe. This is grade 2. Sometimes I think that it is very difficult and risky but possible. And sometimes I realize that it is not safe or not possible. I just leave it. So these 3 are the grading which I like to operate. All large AVMs come in grade 3. They are very difficult. Large AVMs are difficult. Majority of them are high flow, and many of them can be removable. So if you can do surgery, you cure the person. If you cannot do surgery, don't touch and run away from the AVM. That is the answer. So now, this is the AVM. We have to be very, very sure whether it is intraventricular AVM or paraventricular AVM. You see, this is a confusing type of AVM. Intraventricular AVMs are a little bit better to remove. Paraventricular should not be removed. So it is important to understand. So investigations have improved quite beautifully. We tried to make 3D models earlier on in our career, and these models and investigations, you see, these fiber tracks can show you very clearly that it is completely intraventricular, and intraventricular are better for surgery. We all know that. So we introduced these 3D models for AVM, and I think that these are sometimes very important and very crucial. So this is the AVM, as you can see, and this is the AVM on 3D model. And this 3D model, we have recently started color coding it. Like this is the straight sinus, we make it blue, feeding arteries make it red, and we are working on that project. But at present, this is the thing that we get. But imagine we can know exactly where to make the skin incision, how to go and how to decide. These AVMs, these 3D models indeed help us. And this is another 3D model. You see, it can give you extracranial supply and things like that. And it is very important. Now a patient comes to you with severe headache. And this is the large AVM. And I make this 3D model. And this is intraoperative. Now the question is whether you want to, to make a summary, I do not like preoperative embolization at all. But I have operated several cases where preoperative embolization was done. This patient has come with severe headache. Whether you can remove it for headache, you cannot create hemiplegia. For headache, you cannot create death. Means it can happen in our neurosurgical life, it can happen. But there are several issues in this AVM which are good for the surgeon, and several issues have to be understood very clearly. How to attack, where to attack, and how to proceed in the AVM has to be very thoroughly and very meticulously planned before operation. And this AVM is intraoperative. You have all the kinds of investigation. And if you remove it completely, you can give this wonderful smile to this patient, which no other treatment. You give partial embolization, which is useless. You do for this large AVM, it is useless. If you can remove it and give this smile, that is the treatment. And it is difficult. It is philosophical. You have to understand your own capability. This is another patient, young man, a farmer, and comes with this only symptom of headache. Now for headache, if you are removing this AVM and creating hemiplegia, it will not be accepted. So I sent this boy out. I said, no, this is dangerous. Just enjoy the headache, and went away. After about 3, 4, 5 months, he came back to me and said, doctor, please kill me. I said, okay, come. Then it is not, you see, there is no ego and pride when you're deciding on yes to operate and no to operate. It is on the understanding of the AVM, and I managed to give him this beautiful smile. You see, and this is the large AVM which is removed. It is possible. And this is the only treatment. If you can do it, that is the best. But if you cannot do it, that is just, this is another young, very high profile engineer of our country with a top ranking in the Institute of Technology. He came with the symptom of seizures. Now, only seizures, you can give anti-epileptics. Now, there are, you see, this is in the frontal brain. This is quite a straightforward AVM. I think those who will say that this cannot be removed or should not be removed, maybe having not much experience in AVM. This AVM is difficult, but it is elegantly and eminently possible to resect. And of course, there are dangers. Of course, there can be bleeding. You touch the AVM, it bleeds here. And during the time, it can bleed from one side, bleed from other side. It can bleed from multiple sides. It can make a mockery of the theater. So you have to have confidence in your own skills, confidence in your assistant, confidence in your nurse, confidence in your anesthetist, and the whole team has to be with you. And they have to keep, on the other hand, if you create a mockery, the whole team will go against you. So you must remember, you are the one who is responsible, and you are the one who has to remove this AVM beautifully and cure the person. However, I must tell you, you do surgery for epilepsy, so epilepsy may not go. Maybe here and there, but epilepsy certainly reduces in its intensity. Large AVM, when I say when there is anteroposterior measurement on lateral film more than 4 centimeters. You can imagine AVM in the region of brainstem, in the region of vein of Galen, in the region of, you see, it is quite an AVM. And if, you know, what is more important is learn interhemispheric approach. If you learn interhemispheric approach, many of the AVMs get feeders from anterior cerebral artery, from posterior cerebral artery, and both these feeders are elegantly amenable and exposable from interhemispheric approach. This posterior cerebral artery feeders and anterior cerebral artery, you come from interhemispheric approach. Along the tentorium, you get the feeders. Along the tentorium, you get anterior cerebral artery feeders, then come on the convex straight, remove the cerebral artery feeders, and you remove, and you cure. There is a big possibility of curing AVM. AVMs which have bled are more likely to bleed on a second occasion. So in this AVM, if you can imagine, there is a large posterior cerebral artery feeder, which is my friend in AVM surgery. When I see large posterior cerebral artery feeder, I know that this is a resectable AVM. I come interhemispheric, get along the tentorium, get the posterior cerebral artery feeder, and then resect the AVM. These posterior cerebral artery, anterior cerebral artery feeders are good bets during your surgery, and you can remove this AVM. On the other hand, you know that there is a possibility of having a complication if you are not confident enough. So there is no ego or pride in these operations. This AVM you see in a most easiest of all locations of AVM. But this AVM is fed not only by posterior cerebral, it is fed by middle cerebral, it is fed by anterior cerebral, it is fed by contralateral anterior cerebral. This was a very high flow. When multiple territories are feeding the AVM, it is high flow, and it can become a difficult situation to operate. But difficulty means if you can, you know, if you can handle the bleeding, if you can control the bleeding, if your team is ready to handle the bleeding, you can cure the person. And believe me, there is no other treatment. If you give, you know, go on giving some kind of embolization or partial embolization, you can actually harm during the procedure. Whether it helps by partial embolization, very rarely you can absolutely cure the AVMs. So this is another AVM which has bled. Now there are some issues. You see, when I see the AVM, it is not just very heavy vascularity. You find out, you study it for hours, you study and find out what are the good points, what are the bad points during surgery, how you can approach the AVM, how you can resect the AVM, and how you will dissect the AVM. You see, wide exposure is the key. You have to expose when you're doing any kind of AVM, wide exposure. This side, that side, to the base, potentially attack the AVM. And if you have the exposure, you have the confidence in bleeding control. This is the only thing that happens during operation. Control the bleeding, and how you control the bleeding will depend on your experience and on various other factors during surgery. You have to learn how to dissect. You cannot just go on coagulating. You have to dissect, and you have to identify the feeding vessel. You have to protect the venous drainage. You have to do various kinds of things. You know, nobody can talk about AVM surgery and show surgery. What happens is large vessel bleeding. AVM surgery, there are three types of vessels. One is large vessel. Large vessels are easier to control. Small vessels are the key. Don't coagulate the small vessel. You follow the small vessels into the brain parenchyma and find out the mother feeder and then coagulate that mother feeder. There is no point in coagulating here and coagulating there and putting Surgicel and pressure and all those things. There is no point. You have to trace the mother feeder in small vessels and get to the feeder, and ultimately you have to, you see, you cannot remove it partially. You cannot say, I will do second stage, like a meningioma. If you stop halfway, it will bleed to death. You have to, once you have entered, you have to come out successful. If you start jumping in the operation theater and not controlling bleeding, the patient will never jump in his lifetime. So you have to be very, very careful and beautifully decide. These are, if you ask me what operation gives you a big kick now during my 38 years of neurosurgery, I will say this is the operation which gives me a kick. And this is when you get such trophies in your life. These are the trophies you want to show. This is Sylvian Fisher AVMs. This looks very complex, but study it properly. Identify the site of bleeding, identify the feeding vessel, and then go to the feeding vessel. You see, you have to learn attack, that not just coagulation, circumferentially. This is a big, like a dural fistula. You have to just go surround, and ultimately you have to learn and dissect, get to the feeder. This is another AVM with only symptom of headache. Can you believe only symptom of headache with such a massive AVM? Now, you like a meningioma, you cannot say meningioma will come around and this and that. You have to plan, you have to beautifully resect this AVM. And if you are able to do, it is much better than a meningioma. Meningioma is a tumor. AVMs are not tumors. AVM are absolutely nothing. If you remove, it will never recur. This is AVM which has been partially embolized. If it is embolized, it helps, but nothing great. I don't want to put the patient at risk and patient putting unnecessary material inside the head and give a second operation. I have to operate many of these embolized AVMs, but that does not really help me. In short, I do not like preoperative embolization. This is post-operative of that. This is another tumor, another AVM. Can you believe only symptom of giddiness? I think if this patient comes to me today, I will say no operation, but I did it some 15 or 20 years ago, this case, with only giddiness. And, you know, in my excitement, in my this thing, I did this and I did it successfully. And this is the greatest trophy in neurosurgery I have ever got. This huge AVM with large inferior vena cava, large jugular venous drainage, multiple intranidal aneurysm, this AVM I resected beautifully. And this is the post-operative image, and this is the patient after several years. So there is a possibility in your hand. You cannot say, I will not do it. These are, of course, I am showing you the more difficult ones, but there are easier AVMs. And this is another very high flow AVM, large AVM, and this was removed quite elegantly, as you can see. This motor strip AVMs are dangerous AVMs. If they do not have significant symptoms, you try to avoid operation. Now, this patient was referred to me by a very big politician, and I was very, strong. They said, you can only do, nobody can do. This kind of ego thing came into my picture, and I attempted and I removed this AVM beautifully, but this patient developed very significant hemiparesis. So you have to be absolutely, but he has recovered quite remarkably. And I will say motor strip AVM, when it comes, you have to be a little bit careful. If a motor strip AVM comes with bleed, and this bleed, patient will certainly improve after some time. But nowadays, if I have decided to operate, I operate early during the post-bleed situation rather than delaying a situation when hemiplegia is already there, so that you have some comfort zone. But AVM in the motor strips, this is another AVM in the motor strip, which I removed quite beautifully. And this is another one. This is the patient. You can see some hand is drifting, but this patient is cured. Now, possible in young children, when you see young children with AVM, surgery is relatively easier. And this is another AVM. I use this 3D model. I use contralateral interhemispheric approach, which I describe for the first time in the literature to remove this AVM. This is another motor strip AVM. You see, this looks quite a dangerous AVM. But if you slowly, gently, carefully study this AVM, there are 1 or 2 feeding vessels which you can get, and then the vein you can get. And I'm telling you, looks difficult and dangerous, but this was quite a straightforward AVM. This is also AVM, which I very recently did, and this is the post-op. This can be, you see, close to motor strip, I'm not saying that, you have to study this AVM absolutely carefully and absolutely meticulously. This AVM, you see, quite a compact nidus. This can be removed quite safely, and this should be removed. And because unless you remove, there is no other treatment, or leave him. This is another AVM in a very high profile patient, which I did very recently. This is interhemispheric anterior cerebral. So learn the art of interhemispheric exposure and learn the art of retracting the brain. Learn the art of the cerebral artery, posterior cerebral artery, and this can be a relatively straightforward AVM to resect. And this is contralateral approach, another patient, and this is post-operative. This is contralateral approach, which I described for the first time in literature for AVMs. This is another very fantastic AVM in the velum interpositum. Anterior cerebral come from here, posterior cerebral come from here, get this artery, and this can become quite a beautiful situation. This is another fantastic AVM with marginal complaints, and this is post-operative. You see, I now like to, in the left parietal and left posterior temporal AVMs, this patient had some calculation difficulties following surgery. So left parietal and temporal AVMs are more complex. This AVM, can you imagine, with only epilepsy, and I did it several years. I'm not sure if I will do it now in the speech area, but I did it, and she's absolutely cured for several years. This is another AVM. This is another AVM. Imad, you think I have some time? No, I cannot hear. Okay, I cannot. No, Imad, unmute.
Is Vladimir there? He is chairing this session.
Okay, Vlad, I have some time.
I guess that you should be short, so let's make it 1 minute.
Okay, 1 minute. Just see the AVMs. I don't want to talk about it. This is AVM with quite a complex epilepsy, post-operative. This is posterior fossa. AVMs are better. This is AVM I did some 20 years ago with multiple aneurysms. This is another beautiful case, another beautiful case. Intraventricular are much better. Temporal AVM. AVM in the velum interpositum, beautifully removed. Intraventricular AVM, which is fantastically. So these are difficult, impossible cases, but if you can do it, this is pie-LAV fistula, which is another entity, beautiful entity, very easy, not easy, but get to the feeder, and that's the end of the story for pie-LAV fistula. You don't have to resect it completely, but I didn't know this entity a few years ago, and I resected it, but there is no need.
Please, could you go to conclusion, because this is just flipping the images and no one can catch it because it's too fast anyway.
Okay, so I stop. Okay?
Okay.
Okay, thank
No conclusion
you very
on your
much.
side?
Conclusion is a little bit away, my dear Vlad. Okay, just let me conclude. So
Yeah.
embolization has questionable role in AVM surgery. Whether it helps in surgery or not, I'm not sure. It does not make difficult AVM easy. Partial embolization is of no use, and it can have several potential complications. Thank you very much, my dear friends, and I'm sorry if I've taken a little bit more time, and Imad knows that I cannot stop if I start. So if you invite me, you be prepared to accept this.
We were prepared, but not for that map. I know this lecture of yours. It was really not a surprise. But since I probably am not able to show my lecture, then it was all right. Let me once again start to share the screen. If I will succeed or not. I don't think you see it, do you?
No, we see it, it's good.
Yes,
you see it before.
Yeah, we
It's
see it.
perfect.
Yeah.
See it?
Yes.
Come on. Yes. All right, so let's go one forward. Large enough craniotomy well beyond the nidus margins. Open dura carefully. These are the adhesions. You see here the dura flap, and as you return it away, you see the adhesions, and they usually are above the vein. The veins have probably some propensity in growing into the dura, so look at this sharply. Avoid tearing it because your AVM surgery can really be very fast over. This is another such a case. Again, the adhesion, and you see that the adhesions are exactly between dura and the vein. So this is pretty dangerous. Still doesn't work properly. So let's try once again, and if I will not succeed, let's go for the next speaker. Sulcal dissection. Do you see the image?
Yes, it's okay.
Is it okay? All right, so this is the sulcal dissection. The nidus may overlay the gyrus.
Oh no.
Oh no.
It's gone again.
Something's terribly wrong probably with my last try. Let's see the deep feeders, that white matter feeders. Now we are beyond the sulcal dissection, which is the time when you think that you are the best neurosurgeon in the world. Then you come to the white matter and to the deep feeders, and these are almost impossible to coagulate. So the best to deal with them are the mini clips, which either can be removed after the nidus resection or can be left behind. It doesn't really matter. And then the real depth, many of the AVMs do enter the ventricle. Always, invariably, there is a feeder, and this must be sought after actively, and never try to coagulate this vessel. I always use clips to occlude it. This is the ventricle, here is the feeder, and it is the last feeder of the AVM, and I wouldn't dare to coagulate it. I really would close it between the two clips, which is the most sensible way how to deal with this feeder. So by clips. In order to save time, I will go forward. Passage arteries, it's my most important message. I believe that until proven otherwise, all the vessels in the vicinity of the AVM should be treated as passage. See this AVM, here the nidus, and here is the artery, which really looks like being the feeder. And everyone would be tempted to occlude this artery as the first step. Wrong. Just underneath there is some other artery, and going forward, you see that this is the feeder, not this one. And this can be dissected, either coagulated or occluded by clip. And this is after the nidus resection. You see that this looked like original feeder. Has nothing to do with the AVM whatsoever. That's really unpassage. So any artery in the vicinity of AVM may be approach along the vein is very rare occurrence. This is the superior cubiculus small AVM being fed by the posterior cerebral branch. And the only way to get some orientation was this atypical vein. With the use of ICG, see the vessels entering this vein, and we cut all these. And this is at the end of surgery and after. So along the vein, it's not sensible. Atul already has mentioned the use of pre-op embolization. I do not like it at all. In regular AVMs, I never use it. This was the exception. This guy has had 6 embolizations before surgery. This was the last angio when I lost my nerves, and I said, all right, let's resect the AVM. We are well above the AVM. Everything in this area should have been embolized. This is the tentorium. The remnant should be somewhere down in the tonsillar way, and see how nicely it's bleeding. And this is a huge former draining vein, this one. And if you cut it, it's full of onyx, and you see how nicely it's bleeding despite the onyx. And this was the lower part of the AVM. over here. Here is the brainstem, here is the cerebral tonsil, and here is the remnant of the AVM, and it was bleeding like hell. And finally we got by. But I don't think that really embolization helps much, because you have to move the piece of plastic and everything obscured, and always within the embolized vessels, there are vessels which are alive and which really bleed. So whenever possible, without embolization, you do not even have the risk of bleeding embolization procedures. All the surgeries are elective in my hand, with some few exceptions. When there is a hematoma and a small nidus, then we go directly for the nidus and we resect it. But you never get a real good orientation in these cases, because everything's obscured by the fresh blood. This is after surgery. So what we did, there were some 320 cases at this point, and you said that surgical cases grade 1 and 2, of course, prevail. All the other modalities, observation, radiosurgery, endovascular, it's evenly distributed in surgery. We avoid surgeries in grade 4 and 5 only if it's really needed due to repeat bleedings. And grade 3, it's really selective, those larger ones on the surface. In 180 surgical cases, we succeeded 97%, which is the efficacy of the procedure. And we have had 2.6% of complication, surgical complications, not those deficits caused by the initial bleeding. And neither of these complications was in grade 1 or 2. In grade 1 or 2, there was zero morbidity, mortality over the past 20 years. In endovascular group, we have 5% of complication per patient, 0.9 per session, and overall efficacy, especially when using Onyx, was 7%. So this is the comparison of endovascular with 37 efficacy and 8.5% complication, as opposed to surgery, where it was 97 versus 3.4. So this is again something against embolization. 61 patients were sent to radiosurgery, 4% complication, 2 patients bled and died in the latency period, and obliteration proven in 26 out of 45 patients, which is 58% efficacy. In observation group, there were 54 patients, 1 AVM thrombosed and disappeared, which was something which no one would expect, and 3 patients died and bled, which gives 5.5% morbidity, mortality over the 20 years. But we are not Finland, so some of the patients may go lost. So this figure must be taken with some reservations. This is the meta-analysis. Effectivity of surgery is above 90% in all published series. Surgeons simply cannot leave the surgery or cannot leave the part of the nidus behind, very rare exceptions. Patients, again, very uniform in surgery, some 7% procedure. In endovascular, in embolizations, the overall efficacy is something above 20%, 25%. It's a little higher with Onyx, but not much above 30%. Those exceeding publications with 7% efficacy are somewhat suspicious to me. You see, this is our meta-analysis with Onyx, only we get to 30%. The complications, again, very uniform and very same for all published series. It's 7% the same as surgery. Radiosurgery meta-analysis of effectivity, very varied, but we go to something like 60, 64, 65%, the efficacy of radiosurgery, even with repeated procedures in a second stage. And complication rate, again, very uniform, again 7%. All 3 active measures do have 7% complications. When we get the figures from Aruba, which is 2.2% of risk per year of bleeding, and with rupture morbidity mortality rate of 30%. And we project on 40 years, which majority of patients are diagnosed between 30 and 40 years of age. So they have 40 years to live. So here is the perspective in years. And this is the probability of poor outcome given from these figures. The blue line is the natural course. Its effectivity 30% and morbidity mortality of endovascular procedure. In 40 years, we do not bring any benefit to the patient. Simply, it doesn't change the natural course. Radiosurgery is more effective with 7% accumulated over the first half year. Then we are able to cut the morbidity mortality down to 1/2, and there is some effect for the patient 8 years after the procedure. Use radiosurgery in a 70-year-old patient doesn't make any sense. With surgery with its high efficacy of 97% and 7% morbidity mortality, we bring the effect to the patient in 10 years. Should you decrease your morbidity mortality, like in grade 1 and 2 patients, because the natural cause very early on, in 1 or 2 years, there is a benefit for the patient. So this is the graph I use for advising the patients to choose. What about the Aruba, when I mentioned that? The study virtually compared endovascular and radiosurgical cases versus observation, because there were only 5 surgically treated patients, which is negligible, and everything was over very limited time. When we are talking AVMs, we are talking some 30, 40 years of life. Aruba had 33 months follow-up. So this is not really the best information we can get. So the only conclusion for me that unruptured AVMs, Spectral Martin 1 and 2, should not be treated endovascularly or by radiosurgery. Surgery is, in my mind, definitely the treatment of choice for AVMs, Spectral Martin 1 or 2, with no respect to presentation. Good surgery, of course, is superior to radiosurgery, and it's superior to endo and natural, as seen from the graph. Bad surgery, of course, is inferior to anything. So it's mostly about the management decision, which modality to use for which patient. Competence, skills, of course, experience, self-assessment. One must be honest not only to the patient, but also towards itself. Whether I'm able to resect this AVM or not. I'm not Atul. I would be choosing easier AVM than he does. Honestly, information and patient choice is important. I always let the patient decide about the treatment. I lead him somewhere, but the final decision is the patient's. We are always talking about high volume and well-equipped centers, but AVMs are a rare disease, so it's very difficult to concentrate more than 10-15 patients per year in a regular neurosurgical department. To conclude this therapeutic talk, Spectral 1 and 2 is surgery, no respect to presentation. Spectral Martin 3 is heterogeneous group, so the decision is individual. Deep seat, deep drainage, eloquent areas, it's for radiosurgery or even observation. Superficial large ones are good for surgery. Spectral 4 and 5, I don't think that we have any treatment means to offer the patients lower risk than the natural course. So if possible, we observe these patients and we go actively only if we are forced by repeated bleedings, and then we consider all the treatment options and we probably would choose some combination. This is what already Ramesh has mentioned. Never was planned study on surgery after failed radiosurgery. I have had the opportunity to operate on 4 patients after the failed gamma knife treatment, and those were the 4 easiest surgeries for AVM I ever did. So that would be a good combination to treat surgically those patients who failed radiosurgery. use monotherapy whenever possible, because 7% morbidity mortality rate per session in endovascular treatment. Say if I would have 3 endovascular sessions prior to surgery, it means 4 active measures. It represents treatment risks of nearly 30%. With the natural course, which is rather favorable for the patients, I cannot offer treatment which would represent 30% of morbidity mortality. Already one pre-op endovascular session followed by surgery represents the risks of 14%. It's nearly inexcusable to expose the patient to such a high risk. This is what I already have said. All this is put together in a book we have published some 3 years ago with Springer. So I would recommend this for your reading. You see that I have compressed, as Atul is giving his publications one by one, all this is compressed in one book, but it's actually the same advertisement. So do please excuse me once again the failure to show you the images, and thank you for your attention.
Thank you, Vladimir.
I thank you for your patience.
Okay, well, I think now I'll give the venue Roy.
Yeah, Imad. Yeah, thank you, Vlad. I think we're a little over time, and maybe we should go to the next talk. It's Professor Stéphane Florian. Stéphane, could you connect?
Yes, thank you. I will try to do my best in order to
I think, Vlad, you have to share out your screen.
Yes, please.
I did.
Yep.
Sorry for this. Both me and Ramesh are having problems this time. Ramesh disappeared completely. I had these troubles.
Ramesh sent me a message. It was power cut off at the end of the last slide, which he wants to thank for the webinar. So he was completed his presentation.
Okay. Thanks.
Florian? Stefan?
He's frozen on the image.
He has the slide.
He has the slide, but his image is frozen. He doesn't move. So probably everything's frozen.
Stefan, he can't hear. Huh?
He's not with us on the screen anymore.
Shall I go ahead with my presentation in that case?
I guess so. Do so, Roy.
Yeah.
Okay, let me try if mine will work.
Hopefully you are going to be the first without problems.
Oh.
But he has to conclude the session.
Yeah, that's the problem.
This is the punishment for him.
Roy?
Yeah, I'm trying, but okay, let me try again. Share screen.
Did you unshare him? Oh, Florian is here.
Stefan is back. Is back.
Stefan is with us. Unmute
yourself, Stefan. Stefan,
yes, we have a very severe weather here in Cluj, so that's why I sometimes lost my connection. So I'm deeply grateful for your invitation. I'm glad to be along with you, to see you, and really I enjoyed your presentation and presenting after Vladimir, which I consider one of my maestros. He inspired me along of my career. Thank you, Vladimir, for your presentation and for all the presentation you made and inspired me. So, do you see my screen?
You can share
share your screen.
Okay, I will try again because I don't know what's happening.
I am the last to give the advice, but you have to share twice. First, share the yes.
Yeah,
Yes,
it's okay.
now. It's okay?
It's
Yes.
okay. Yes.
Okay. So many of the things I would like to present were there already presented. I will not insist on general data. My topic is on pediatric vascular malformation. So I will talk about AVMs along with the cavernomas I operated in the pediatric population.
Eva, guapísima. Mira, nada.
So there are in pediatric age, AVMs represent only 33% of all AVMs. In our experience, it's a little bit higher. The
Ahí
percentage.
está. La
Miguel,
segunda
mute yourself, please.
es
Miguel,
que,
Miguel,
bueno, yo
please
vi el
mute
otro día el
yourself.
caso y vi el informe que hablaba de meningioma. Total, que yo me
Miguel,
quedé.
Miguel?
he's muted. All right.
Yes, he's muted now. Okay. In pediatric age, they tend to rupture more frequently than in adults, and these are the most common cause of spontaneous intraparenchymal hemorrhage in children. The factors influencing hemorrhage based on the literature are firstly the fast arteriovenous shunt and deep-seated or infratentorial AVMs. Related to my personal experience, I operate only 34 cases among the 238 cases of AVMs in the last 21 years. The pediatric in the pediatric age, the girls tend to be a little bit more frequent than the boys, and generally speaking, in all series, there are 2 peaks of incidence. Regarding the pathogeny of cavernomas, there are many more unknown features than the known ones, and there is a clear tendency of multiple cavernomas in some cases with mutation in 3 genes, CCM1, CCM2, CCM3. There are 2 types of hemorrhage, but regarding the history, the natural history, each patient appeared to have their natural history. There is an increased risk of bleeding in brainstem cavernomas up to 60%. That's why when I have a brainstem cavernoma that already ruptured, I rather prefer to operate than to wait too much. So the clinical presentation in the pediatric age, it's represented mostly by hemorrhage, but also in adults. Seizures, it's also quite frequent modality of presentation, but I only had some cases with progressive neurological deficits. I do not operate patients with AVMs with only headaches as a complaint, except the cases in which there are clear indications for surgery related to the location and dimension and the grading of AVM. So, as I mentioned, in most of the cases in the pediatric age were presented with hemorrhage and only few with seizures. In pediatric, seizures and progressive neurological deficits are equally presenting in our experience, and hemorrhage, especially in brainstem and posterior fossa, was the most frequent cause of surgery in our experience. How to manage, I will not repeat, that was already presented by Vladimir in the previous presentation. He inspired me, and you see the probability of bleeding in 30 years perspective was already presented. There are many arguments against the the conclusion of Aruba and Scottish audit studies, I am in favor of surgery in many of the AVM cases. We here in Cluj, we have a particular position because we don't have yet the possibility to treat it endovascularis. For endovascular treatment, we should send the patient in another center, and that's the reason for in cases with AVMs or even aneurysm, I rather prefer to operate. The advantages of surgery are immediate elimination of the hemorrhage, decrease of the rebleeding risk of AVMs, improvement in seizure control. Based on the recommendation of on the literature and on the experienced neurosurgeon, grade 1 and 2 AVMs, class A special ports are microsurgically removable, and they obtain the most favorable long-term results. Grade 3, most of the experienced surgeons are in favor of surgery at this grade, and in grade 4 and 5, the surgery has a palliative role, but we still obtain some good results in cases admitted with hemorrhage, with large hemorrhage in such difficult cases. So the most versatile and curative options for many patients, it's represented by surgery. Risk of surgery, it's quite high, but it's highly dependent on the dimension and venous drainage of the AVMs. And based on the study of Morgan, you see here the morbidity and mortality, it's increasing from 1% to up to 38% in cases with AVMs larger than 6 centimeters and with both DVD and eloquent location. So what are the factors that are influencing the results? There are AVM-related factors for sure, because as we already demonstrate in many of the cases we operated in the Spencer ports and grade 1 and 2, especially cases, 33 cases, we obtain in the large majority of cases very good result. In Spetzel-Martin 3, we also have the large majority of cases with good and very good results. But as I already mentioned, even in cases with Spetzel-Martin 4, we have the majority of cases with good and quite good results. And even in grade 5 cases admitted with hemorrhage, we obtain some very good results. So really, when you have to choose in between do something in order to save the life of patient and do nothing, I rather prefer to do something, to do my best in order to save the life of the patient. So as I mentioned, the factors that are influencing the surgical results are AVM-related. Large AVMs are quite difficult, location, and especially in posterior fossa and brainstem, presence of hemorrhage, diffuseness, and patient-related factors are also influencing the surgical result. But I consider that the most important is the surgeon-related factors, and this is the experience of surgeon and how you can deal with this. And Professor Goel and Professor Benes already presented this. It's highly dependent on the experience of the surgeon. So this is a case with an AVM 80 years presented with seizure, and it was a small bleeding around the AVMs. We admitted the case. We decided to operate, certainly discussing with the patients, with the relatives, with the patient, and it was finally the decision of the patient. And in this quite difficult location, we prefer an interhemispheric occipital approach with operated side down in order to take advantage from the gravitation. You see, I rather put some retractors. I don't like to use retractors, but I'm not completely against them. But in this case, having the gravitation along with us, we can dissect and progressively. Sometimes you can have some bleedings. I'm not afraid about these bleedings if they are not too catastrophic. If a bleeding is coming at the beginning of the operation for certain causes, it's really hard, especially if you interrupt the venous drainage. But otherwise, all these small bleedings can be controlled by aspiration. I rather prefer to use the coagulation with an power a little bit higher than in meningioma surgery for some parts of the AVMs. And as already presented by Vladimir, I dissect and I try to identify the en passage. And finally, we obtain a complete removal of the AVM, which was considered in another center being not for surgery. And the patient was without neurological deficit. So regarding the presence of hemorrhage, many authors are underlining the fact that it has a favorable influence because it separates the portion of the nidus from adjacent brain, and there is no need for cortisectomy, no need for no additional morbidity. But based on our prospective study, we demonstrate that the presence of hemorrhage has an unfavorable influence because of the mass effect, because it could mask on a subjacent brain AVMs with false negative angio-CT. And there is clear an inverted linear correlation with high statistical significance based on our published data. So another factors, the presence of hemorrhage. This is a case admitted 78 years girl admitted in coma with this hemorrhage and intraventricular hemorrhage. We enter in emergency. You see it was a bulging brain and very angry brain. We entered directly to the hematoma in order to first decompress the brain, and then we try to identify the vessels, the feeders, and certainly the surgery is not so easy. It's bleeding quite hardly, but with patience and with experience, you can manage to occlude all these small, deep-seated vessels and progressively remove the tumor. You see, at the end, we have a relaxed brain, and I will go a little bit faster. And at the end, we obtain a complete removal with a relaxed brain. We put a ventricular drain in the ventricle, and I also consider that in deep-seated, you should enter the ventricle and to occlude the feeders coming from the posterior choroidal artery. It was this is the immediate postoperative angio-CT. You see the complete removal. The brain was well vascularized, but unfortunately, in a couple of days, we had decline in neurological status. On angio-CT, you see that black brain and pulmonary complication, and finally, we lost the patient. So this is another case with an pineal region spinal region, AVM. I will not insist. It was quite similar. The best results in surgery are obtained by experienced neurosurgeon. But related to the cavernomas, I am in favor of observation for asymptomatic lesion, incidentally discovered brainstem cavernomas, and deep-seated supratemporal lesions, which are not active. And there is no medication other than anti-epileptic therapy in cases with seizures. I recommend sometimes to the patient to take some C vitamin in order to reinforce the capillary, but there are no studies in favor of this recommendation. So surgery, it's recommended in solitary asymptomatic if they are accessible, easily accessible in non-eloquent areas. Surgical resection may be considered in deeps if symptomatic or after prior hemorrhage, and it may be reasonable to offer surgical resection of brainstem after a second symptomatic bleed. It's the opinion of some authors. This is the case with an parasagittal cavernoma. The patient was presented with seizures. We enter interhemispherically, and I always choose the natural route in order to achieve the cavernoma. So transsulcal, you see here the pericallosal artery. Then we identified the yellowish tissue surrounding the cavernoma, and then with a progressive dissection around of the cavernoma with concomitant coagulation, we completely isolate and dissect the cavernoma, and then we completely take out. In this superficial lesions, the surgery is not so complicated. The problem is related to the brainstem cavernomas. In those located in the surface of the brainstem, we have a clear approaches, like in this particular case with an location in the upper brainstem and mesencephalus, we removed to a subtemporal approach, and in this case with a peritrigeminal approach. But in those located a little bit deeper, there are some challenges. The cases with the brainstem hemorrhage, I do not recommend, and I do not enter through the fourth ventricle flow, except the cases in which the cavernoma and the bleeding of the cavernoma creates its own opening in the fourth ventricle flow. So it was the case in this particular case. You see, after the opening of the cisterna magna and with a telovelar approach, we reach the fourth ventricle flow, and you see here the hemorrhagic point, and we enter through this small opening, and we take advantage of the elasticity of the brainstem and took out the hematoma firstly, and then after a dissection we took out also the cavernoma. And this is the control. You see how deep it's located, and we took the advantage from the bleeding in order to reach the cavernoma and to remove. Otherwise, it would be quite difficult to operate and to enter in the middle of the pons. And in this particular case of the brainstem cavernoma with a lateral postomedullary sulcus approach, we enter also telovelar, and then we open the pontomedullary sulcus. We enter the cavernoma the hemorrhagic cavity, and then we dissect and removed completely the cavernoma. In brainstem surgery, I am not in favor of removing all of the yellowish tissue. A particular problem is related to the infants with bleeding cavernomas. I published maybe the smallest two cases. One was 5 months and the other one 7 months, in which I enter and I recommend operation after the first bleeding, because waiting at this age of a child, waiting for second bleeding, it could be too dangerous. And the surgery, it's not quite different from the surgery in the adults. Once you know how to approach, this is through a peritrigeminal area approach with to retrosigmoidean approach. You see, we remove the hematoma and the cavernoma along with the clot, and then we check the cavity, and we completely remove the tumor, and the patient was incredible well after the operation, and he established in few months. This is another case with them. So I will go directly to the take-home message. Surgery of intracranial vascular malformation in childhood is not essentially different from that of adults. We are applying the same principles of surgical planning, the same microsurgical technique, and the same microsurgical gesture. What is different is the long life expectancy, resulting in more years of living with an undetonated bomb in the head. As a consequence, a more aggressive approach is maybe advisable and medically justified. Always remember that child is not a miniature adult, is more than that. Child is better supporting the surgery, more rapid recover from surgery, frequently present spectacular recovery from severe perioperative disability. So these are not only images, these are lives. There are hopes, there are dramas. These are unique person, not case series. Treat them with the deserved uniqueness. Thank you very much for your attention.
Thank you, Stefan. Do we have some comments or questions to Stefan?
Stefan, excellent. Thank you very much. Very good lecture. Thanks.
Thank you.
Thank you. Great. Thank you.
Right. Imad or myself to introduce Roy.
No,
you should share the session so he can introduce himself.
No, you are the chair of the session, Vladimir. As long as you are here, you present.
Okay, I shall introduce Roy, and I shall then disappear. Roy, please, the floor is yours, and thanks for the best at the end.
Okay. Yeah, I'm just trying. Entire screen. Okay. We're okay. Yeah. Can you see my presentation or not?
No.
Is it not? Which one? It's not clicking.
Sharing is caring.
It is?
No, Roy.
Somebody, multiple panelists.
We still have all the panelists there and nothing of your screen. We have some problems today, Matt. The technical ones. I had problems.
Okay.
Roy,
seems
okay. Very good. Okay. Roy, go ahead, please.
Okay, so we'll change the topic a little bit. Thank you, Imad and Vladimir, for inviting me. From AVM surgery, we come down to a technique that we discovered and reported recently, that will really change vestibular schwannoma surgery, I believe. It's the ability to stimulate a sensory nerve, and I'll just share with you our experience in that. I have no disclosures, and we know what we're dealing with. We, at least in our unit, we only operate on the large and the giant. We do not operate small ones. So this technique and this series essentially deals with the large and giant schwannomas. We do know that the results for facial nerve preservation in the best of hands, like Professor Sami, for the large tumors is not all that great. So you could see here, there are a large group of patients who do have facial weakness after, but what is needs to be seen is that you can just forget about hearing when you're dealing with total excision of giant vestibular schwannomas. Even when they are small vestibular schwannomas, the percentage of patients who have preserved hearing after total excision is small. On the other hand, at least for small tumors, we know that radiosurgery is a very effective treatment modality. But when you have when you have large vestibular schwannomas, obviously you cannot treat that with radiosurgery. But the problem is the fact that patients who come to us with large tumors, they expect the same kind of results that radiosurgery gives for small tumors, and that's where the challenge is. The problem with radiosurgery for large tumors is that when you do the dose volume curve, you have a significant amount of radiation that goes to surrounding tissue. So therefore, radiosurgery is not applicable. And that's where this idea comes from, in which you do a subtotal excision and you convert a big tumor to a small tumor, and you treat the small tumor with radiosurgery after 6 to 9 months. So this is a paradigm we developed in the last little over 10 years now, with the idea of facial and cochlear nerve preservations. Essentially, it's a nerve-centered approach, and the tumor is in the way. You remove subtotally the tumor, but you concentrate on the facial and the cochlear nerve. So this is a cartoon that shows you that what you're planning to do is you remove all the capsule except the capsule covering the 7th and the 8th nerves. So it's a small, thin capsule of about 1 to 2 millimeters that left in the shape of the facial and the cochlear nerves, and you just wait for brain pulsations for 3 to 6 months, and hopefully it will shrink and form a small ball, which will be an ideal target for radiosurgery. So that's the idea of the subtotal excision. Just to show you, we now have 70 large vestibular schwannomas consecutive treated with this approach. And as you can see, almost all of them had good facial function before, except for a couple of patients. But what's interesting is even with large and giant tumors, you have about half the group that come with useful hearing. So it is an important consideration. So this presentation is about how to keep hearing intact. Most of these patients had microsurgery as first treatment, but there were some who had gamma knife before. What are our results? Our results for facial nerve in this group is very, very good. One patient had a transient deficit which completely recovered. So the results are 100% for facial nerve preservation. But what's more important is cochlear nerve preservation. So in this group, we had 42 patients with 1 to 3 Gardner-Robertson hearing, and we were able to keep it up to 93. And if you look at, let's say, useful hearing, which is Gardner-Robertson 1 to 2, the rate of preservation of hearing for the group who came with useful hearing before surgery is 88%. So it's excellent. So these are the usual delays, about 6 months between the two treatment modalities. Our mean follow-up is over 3 years now. We have had no new cranial nerve deficits, but 4 of the patients required BP shunts, probably due to absorption problems, which needed treatment. This, when you do not remove the whole tumor, you open yourself out to having failures. So we have had 6 failures in this group, and 5 of them, these are younger patients generally. 5 of them, in this group of 5 patients, we did a second combined approach, exactly the same thing. with very good results. I mean, 5 patients, all 5, we had normal facial, and 1 patient we had Gardner-Robertson 1. And 1 patient had a second gamma knife, and it's controlled, and it's remaining after more than 3 years, and the volume is decreasing. So even if you have a failure, this approach can be done again. And what happens to hearing in the long term, it's impressive to see that the combined approach, which is surgery plus gamma knife, is exactly like the results for hearing for the patients with small tumors treated only with gamma knife. So this is the graph that shows the probability to remain in Gardner-Robertson 1 during follow-up. But do not forget that hearing can drop because of gamma knife, and that happens up to 7 years. But once you've cleared 7 years, then it kinds of plateaus off. So if you can keep hearing till 7 years, you're likely to keep hearing afterwards. So this is the stimulation methodology. So seventh nerve stimulation, everybody does it. So it's nothing to talk too much about. But just to show you this example of a dorsal 7th. So very, very rarely you can have a 7th nerve on the posterior aspect of the tumor. Most of the times it's pushed anterior or superior, but when you can rarely have this dorsal presentation, and you have to take extreme care of that. How do you stimulate the cochlear nerve? So this is a slide that shows you that. Now here you can see the tumor being dissected off the nerves here, and we have come up to, I'll just run this through, we have come up to the superior aspect of the facial nerve that you can see there, and then we are trying to find the cochlear nerve below. So this is the only part of the capsule which is left, which is on the cochlear and the facial nerve, thinning out progressively, and stimulation here will show you 7th nerve stimulation that's positive. And as you go inferiorly, yeah, there we're lifting it off the 9/10 there, and then on this surface we got positive stimulation for the cochlear nerve. So, and this entire capsule can then be removed. So that's your stimulation for the cochlear nerve that you see there. So finally, we ended up leaving a very small piece of capsule on the 7th and the cochlear nerve, leaving you with an image that shows something like this, very thin, right on the facial and the cochlear. So this is summarized in this article that came out last month in JNS, and I'll just go through the current cochlear monitoring techniques that are available worldwide. Almost everybody uses the brainstem auditory evoke response. It is a continuous monitoring of auditory activity, and there are well-defined alert criteria because people have been using it over 30 years. But the problem is there is a delay in response because of the data averaging. The signal to noise ratio is not all that great, and the temporal resolution is poor, but it never allows nerve localization. You only know if you miss this peaks here, we know that the nerve has been cut, and then it's too late to save hearing. So it allows you to be kind of okay to say nerve is preserved till now, but nothing more than that. People try to look at what's called the cochlear compound nerve action potential, because it has obvious advantages over BAER, because it's real time, the amplitudes are larger, there's less averaging. But then what you need to do that is you still need to keep a recording electrode on the nerve. And when you have a tumor there and you're removing tumor, this electrode gets displaced all the time. Therefore, it's impossible to do it for large tumors. If you are doing it for very small tumors, maybe it's a possibility. But in our clinical situation, we could never ever get the compound nerve action potential. So this is the reason why we decided to figure out a way to stimulate a sensory nerve, similar to how you would stimulate any motor nerve or motor nucleus in the head. So we've been playing around with this stimulation for many, many years, and we figured out that the best way to do it is to focus on a small muscle that you see here, which is the posterior auricular muscle. And it is in clinical practice, it has been known to have a response. So it is a sound evoked myogenic response. That means this is in clinical practice, you stimulate, you give click stimuli or some kind of stimuli to the ear. The impulses go along the cochlear nerve and goes to the cochlear nucleus. And then there is fibers go to the medial facial nucleus, from where it comes out via the nerve, facial nerve, to innervate the posterior auricular muscle. So this is basically, we are doing a trick, and we are using a reflex to stimulate a sensory nerve. So if you were to stimulate the sensory nerve and use the facial nerve to record it, then you can kind of figure out that the cochlear nerve is intact, and you can tell where the cochlear nerve is. It's a very small muscle that we discovered with our dissections in the lab. Most people cannot move this muscle. It's a very small one voluntarily, but some gifted individuals, like a good friend of mine here, can move it voluntarily. I hope you guys don't recognize him, but some people can move it voluntarily. Under anesthesia, you would give general anesthesia but avoid muscle relaxants. You can use the same electrodes that you use for BAR, that is CZA1, which is on the mastoid process near the muscle on both sides. But you will have to do continuous EMG recording of all the motor nerves, that is 7, 9, 10, and 11. And here you can stimulate directly. So what do you see? I mean, look at this intra picture. That's where the cochlear nerve is. And you can see the 9, 10. They're very close. And obviously the facial nerve is also very close on the other side, on the hidden side of the tumor. So if you were to stimulate with, say, let's say 2 milliamperes, you would get stimuli in the 7th nerve, maybe in the 9th, 10th, and also in the cochlear nerve. But when you play around and reduce the stimulus to 1 milliampere, you see that only the posterior auricular muscle is activated. So the other 7th nerve muscles are not activated. So that's important to kind of differentiate that the impulse that you're giving does not go directly to the facial nerve, but it goes through this reflex to the facial nerve indirectly. And that's quite evidenced by the results in our patients. When we look at the cochlear nerve here, the latency is 11.6, which is much more than the others because it has to go across a synapse. But at the same time, the amplitude is very small. Why? Because all the other muscles innervated by the 7th, 9th, 10th are huge muscles. But if you remember the size of the posterior auricular muscle, it's a very small one. So the amplitude is much smaller and the latency is longer for this evoked response that goes through a synapse. So based on our experience with now this consecutive series, about 70 patients, hearing preservation is possible in the large majority and all patients with facial. There is a learning curve for the surgery and also for radiosurgery. But the important thing is that you can match the expectations with large tumors that patients have when you treat for small tumors. And we find to keep hearing the cochlear posterior auricular muscle response is a very useful technique to figure out where the nerve is. Thank you very much.
Thank you very much, Roy. I think Vladimir has, I'm not sure he left already. Yeah, Vladimir has to go. He's a birthday boy. He has to celebrate. And it's a wonderful presentation. And I think it's a major introduction on the impact of this technique for the best outcome, because always our concern, these giant tumor, how we will handle them, leave something, leave a capsule, where to leave the capsule. My problem sometimes when they are giant, the tumor is, the facial nerve is not crossing from one side to the other. Sometimes it's displaced up and lift goes around the tumor, sometimes comes medially, sometimes laterally. It's very difficult to identify the course of the facial, even in the best hand technique. And I think this is a great introduction to stimulating the small muscle and get information and feedback. Wonderful. Come together. I think Miguel has some questions.
Thank you very much. Roy, excellent presentation. Thank you very much. Just apart from congratulating on this outstanding presentation, a couple of issues. One of them, whether you have any trick or any nuance apart from the classical, well-described, let's say, subarachnoidal dissection, very well described by Professor Sami? And second, whether in your cases of total removal, how do you manage the intracanalicular portion? Do you always left behind this part, or in any case you open the internal auditory canal? These two questions. Thank you very much, and congratulations, Roy.
Thank you, Miguel. Yeah, so these are usually frequent questions we get. The basis of subarachnoid dissection of vestibular schwannomas, I also picked up from Professor Sami. It's essentially the bimanual technique to get to the correct plane and without any use of bipolar. So this is the key: no bipolar at all. Bimanual technique and to peel off the arachnoid of the nerves. But the challenge for nerve preservation in large tumors, I'm talking only about large and giant tumors. In small tumors, it's different. In large and giant tumors, the facial and the cochlear nerve are extremely thin. And even if you do the best bimanual dissection and try to peel off the residual tumor from the cochlear and facial nerve, you're likely to lose the small vasa nervura that go to these nerves. Only in large tumors. In small tumors, I know it's possible to do it. But in large tumors, the nerve is already very thin, and the small arteries that go to the nerve, the facial and the cochlear nerve, is very, very difficult to preserve, and you're likely to lose it. So essentially, if you enter into the plane between the nerve and the tumor over the seventh and the cochlear nerve, the chances of losing it in a large tumor is over 50%. And that's why we changed our paradigm to look at the nerve, and therefore we are just concentrating on keeping nerve function intact. So we are willing to leave a thin layer of capsule 1 millimeter thick based on electrophysiology. So you stimulate from inside the tumor and you stimulate from outside where you know the nerve is, and then you calculate that thickness. So when you reach 1 millimeter, you know that that thickness of residual tumor that you're going to leave behind is only 1 millimeter. When we have that, all the way from the internal auditory meatus to the brainstem, we get 1 millimeter thickness, and then we leave that tumor. So therefore, it doesn't make much sense to be very exploratory inside the internal auditory meatus, unless there is something that is causing a problem by compression. So rarely you have patients who present before surgery with facial nerve weakness. Those patients will require, which is a rare thing, those patients will require a total opening of the internal auditory meatus to decompress the seventh nerve. But most of our patients don't have seventh nerve at presentation. Half of them have almost useful hearing. So I don't think you need to remove that part in the internal auditory meatus, because in the cistern you're going to leave a thin layer, and that part can be easily included in the radiosurgery target. So I don't chase these tumors inside the canal, because I've already decided to leave a thin bit of tumor and to treat it with radiosurgery after 6 months.
Perfect. Thank you very much.
My question, you cannot apply the same principle on that capsule, the same in the intracanalicular, because you can still use the thin stimulation around and debulk that tumor from within, or you feel this is still risky?
It's very risky because you are never drilling the anterior surface of the canal. You can only drill the dorsal part of the canal. So if you want to get on the other side of the nerve, you need a 360-degree drilling. So I don't think it's worth it,
But I agree with you. Any other question or comment to Roy? It seems you are all tired, but I like that you stay to the end, even with the difficulty today. I'd like to thank Francesco for staying up to the end, Miguel, and a special thanks to Professor Iskander Wozniak for his. I hope that things will set it for your country. I'm very happy and blessed that you are with us, and it shows that neurosurgery is still there and in good shape with your presence. So keep the spirit up, and I think I thanks everybody who was there. Anybody want to say something? I see your hands, Francesco.
No. I can say that I appreciate too much this session, this afternoon, this webinar, and this was a great occasion to honor a great friend, Armando Bass. Okay, this is our feeling. You agree, Miguel? Our feeling is that friendship
100%.
is friendship. Nobody can touch friendship. Okay.
100% in agreement, my friend.
Okay. All right.
Absolutely.
So a good night, and for the next time. Thank you.
Okay, all the best. Bye.
Thank you.
Thank you. Thank you, Imad. Thank you, Vladimir.
Bye-bye.